So thank you so much for your patience. So we'll be moving to the third presenter. The third presenter is Professor Titi Lola Aderonke Samuel, and she's a professor of biochemistry at the College of Medicine, University of Lagos, with over 3 decades of experience in teaching, research, and academic leadership. Our research is focused on endocrinology, oncology, molecular biology, public health, with significant contribution to breast cancer research, polycystic ovarian syndrome, and contraceptive-related metabolic disorders. She has mentored over 130 undergraduates, 36 MSc students, and 7 PhD students, and have secured multiple national and international research grants in the course of our academic career. She has done several researches, and her research has been focused on understanding.
Recording in progress.
As we focus on understanding metabolic syndrome in women with polycystic ovary, effects of folic acid on insulin resistance, and mineral composition. She has led studies in breast and prostate cancer genetics, including BRCA genes, mutations, and microDNA expression in Nigerian population. She has a very heavy CV, to which I'm just doing my very possible best to, summarize to the best of my knowledge. She has several honors and fellowship program, and she's the current head of Department of Biochemistry, University of Lagos. She has won several awards, involved in several studies, TechForm study on genetic variants of epigenetic fingerprinting of prostate cancer in Nigeria. She was the principal investigator. She was a team member of exploring genomic signature of prostate carcinoma from circulating tumor cells, and she has been involved in genomic profiling of polycystic ovarian syndrome in Nigerian patients for improved prognosis, precision, and personalized management. Please join me as we welcome Professor Titi Lola Aderonke Samuel for our presentation on accuracy of biomarkers in the diagnosis, in ensuring proper diagnosis. So she's taking the topic, accuracy of biomarkers for proper diagnosis. So Professor Titi Lola Aderonke Samuel, ma. Thank you, ma.
This afternoon is accuracy of biomarkers for proper diagnosis. And my name is Aderonke Samuel, the current head of Department of Biochemistry.
Can I share from my side, which I was already doing, so that this can rest? Or do you want to do this?
No, I think it's settling. It's settling, ma. It's settling, ma. I think it will go smoothly, ma. Yes, ma.
Okay, so this would go, or should I do it from my side?
No, this will go, ma. This will go, ma. Yes, ma.
Can we continue?
Of Lagos and the EMSON Welfare Secretary. Let's look at the keywords. Biomarkers or biological markers is a measurable substance in the body, and it's either measured from the blood, the urine, or the tissue that reflects normal or pathological processes or response to treatments. They are essential in diagnosis, prognosis, monitoring, and therapeutic decision-making. For proper diagnosis, a biomarker must be accurate, it must be reliable, it must be reproducible, and it must be clinically meaningful. Accuracy ensures that the biomarker correctly reflects the disease status, avoiding false reassurance or unnecessary treatments. Now, what are the components of biomarker? What makes biomarker accurate? The first thing is there is what we call the analytical accuracy. And this refers to how close the test measurement is to the true value. And this is influenced by one, what is the method used? From one method to the other, accuracy can differ. Did you calibrate or did you standardize the machine that is used? Can the test you carry out be reproduced? And how did you handle the samples that you have used to detect your biomarker? Sometimes mere collecting sample at the wrong time of the day would definitely give you a wrong value. How you store is important. How you transport is very important. There are some materials that you must store under ice. Some, it's okay. Some, you cannot even transport them. You must carry out the analysis where you have collected them. And so these are called the analytical accuracy. Now, there is also what we call the clinical accuracy. And this refers to how well the biomarker you have chosen distinguishes between disease and health in real-life patients. And this is determined by sensitivity, specificity, predictive value, and ROC analysis. And we will go one by one through sensitivity, specificity, predictive value, and ROC analysis. Now, these that we have mentioned are the key measures of diagnostic accuracy. Sensitivity. Sensitivity is the probability that the test will be positive when disease is present. And if you see that formula, that is the formula to calculate sensitivity. TP over TP plus FM times 100. We will see what TP and FM stands for. TP is the true positive. The number of people who actually have the disease and the text correctly identifies them as positive. Example is that a patient has malaria and the malaria test shows positive. Meanwhile, FN is false negative. The number of people who actually have the disease, but the test says it is negative. So a patient will have malaria, but the malaria test will come back negative. So that is how you calculate the sensitivity of the diagnostic biomarker you have chosen. In simple terms, TP are the sick people that are correctly detected. FN are the sick people, but they are missed by the test. That's why sensitivity measures how good a test is at detecting the disease when it is truly there. So if the test or the biomarker you have chosen is highly sensitive, you will not have too many false negatives. So sensitive test, when negative, rules out. That's the mnemonic that you use. And it is acronym SNOT, meaning that when negative is ruled out, your test is sensitive. And so there are so many examples. D-dimer is a blood test marker for active clot formation and breakdowns, and it's mainly used to rule out serious thrombotic events. This is used in venous thromboembolism. It is very, very sensitive, and it rules out any other thing. So this is a sensitive, if you use the D-dimer as your biomarker, it is a sensitive test for venous thromboembolism. So understanding sensitivity and specificity. The basic fact is that people can be sick and it is represented by the sad faces, or people can be well, represented by the smiley face. A test can be positive and a test can be negative. But there are 4 positive test outcomes and only 2 can be right. There is the true positive where the patient is sick and the test is positive. And there is the true negative where the patient is well and the test is negative. But there are two wrong tests where the patient is sick, but the test is negative, or the patient is well, and then you have a positive test. This is telling us about how biomarkers need to be sensitive and need to be specific. So the second analysis is specificity. And this is the probability that the test will be negative when the disease is there. And the formula is specificity is equal to Tn over Tn plus Fp times 100. Tn is true negative. The number of people who do not have the disease, and the test says negative. So a healthy person without malaria, the malaria test is negative. False positive is the number of people who do not have the disease, but the test incorrectly says they're positive. So you have a healthy person who do not have malaria, but malaria test comes back and says the person is positive. In short terms, Tn is healthy people correctly identified as healthy. Fp is healthy people wrongly labeled as sick. So high specificity will reduce false positives. So specific test, when positive, rules in spin. That is the mnemonic that you use for specificity. An example is that you have antibody against hepatitis C virus. It is a very, very highly specific biomarker to detect hepatitis C. So if you carry out a test and that test is highly sensitive, you will only have very few false negatives. But if the test has no specificity, then you will have many false positives. So that is the difference between sensitivity and specificity. Predictive value. This depends on disease prevalence in population. Positive predictive value, PPV, that's the probability that a patient with a positive test truly has the disease. Negative predictive value, NPV, is the probability that a patient with a negative test truly does not have the disease. An example is HIV rapid antibody test. Positive predictive value is higher in high prevalence setting, as you can see from the diagram to my right. There's also what we call the likelihood ratio. This combines sensitivity and specificity into one measure. So there is positive likelihood ratio and there is the negative likelihood ratio. If LR is more than 10 or less than 0.1, then that biomarker provides a strong diagnostic evidence. The next analytical value is ROC curve. That's one you plot the graph of sensitivity versus, versus specificity, and you check the area under the curve. If the area under the curve is 1, it's a perfect test. If it is less than 0.5, then it is a useless test. ROC helps to determine the best cutoff point for diagnosis. And you can see an example of sensitivity plotted against specificity. The blue curve, the blue line, shows how sensitive and specific change at different test cutoff. The red broken line represents a test that is not good enough because it is, the AUC is 0.5. The closer the curve hugs the top left corner, the best accuracy. So for this test that was carried out, the AUC is 0.87, meaning that the biomarker that was tested here is fairly accurate. Now, there are factors affecting biomarker accuracy. The first is biological factor. age, sex, comorbidity, genetics would definitely affect biomarker accuracy. Pre-analytical factor, was the person fasting? Was there contamination in the sample? Was the sample properly stored? All of this would affect the biomarker accuracy. Analytical factor, like we have said earlier, the equipment calibration, lab error, reagent quality will definitely affect the biomarker accuracy. The cutoff values, if the cutoff value is too low, that means the test will be too sensitive but less specific. If it's too high, it will be more specific but less sensitive. Example is the PSA cutoff for prostate cancer. Well, the low value improves detection, but there are a lot of false positives. Finally, population differences also affect biomarker accuracy. Your ethnic and environment variation influences normal range. What you have in front of you are examples of some biomarkers. The accuracy, the sensitivity, specificity, their limitation, and the common diseases the biomarkers are used to detect. Of course, I know you know some of this, you even know more than what I have here. How do you improve diagnostic accuracy? These days, nobody uses just one panel. So there is now a panel, meaning several biomarkers put together instead of just using a single test. So there is no way the panel, at least if you have a panel of 4 biomarkers, 2, 3 will be sensitive and specific. You can also perform serial measurements to detect the trend, and you can use stratified cutoff, meaning that for 50 to 60, you might have a cutoff that is different from 10 to 20 years old. The cutoff for male will be different from the cutoff for female, and the cutoff for Caucasian will be different from the cutoff for blacks or for whites. You can also integrate biomarkers with clinical findings and imaging. Now, these days, novel biomarkers with high specificity are being developed. For example, neutrophil gelatinase associated lipokaline is now a better biomarker, and it is becoming the emerging biomarker in kidney diseases. NGAL is novel, it's sensitive, especially for early detection of acute kidney injury and for monitoring of kidney health. It is often rising way before creatinine. We used to use creatinine before, but now NGAL has been found to be novel, more sensitive than creatinine. Now, what is the summary of what we have done today? Biomarker accuracy is vital for correct diagnosis and patient safety. Analytical accuracy, meaning lab precision, clinical accuracy, is diagnostic validity. Sensitivity rules in, specificity rules in. Predictive values are influenced by disease prevalence. ROC curves help choose the best cutoff. Interpretation must always be in context of clinical findings. Well, you might say, but all of these that we're saying, I'm glad to tell you that in our university, University of Lagos, where multi-discipline research is encouraged, is the Center for Genomics of Non-Communicable Diseases and Personalized Care. And in that center, I am the deputy director. Incidentally, Professor Fasomade is one of the team members of the metabolic disease the disease department. Now, our team is that number one, we implement multidisciplinary translational, basic molecular, clinical, and epidemiological and behavioral research. And we are, in doing that, looking for how to look for more novel biomarkers. And we're doing that every day. We just finished a research and we were able to narrow down to 26 other genes in prostate cancer amongst Nigerians. 26. Meaning that in collaboration, which we're also doing with diagnostic companies, we can actually begin to have method of diagnosis that is specific for Nigerians. And this would help us to discover disease risk stratification, to predict diseases, for early disease diagnosis, for treatment, for prevention, and for prognosis, especially of the non-communicable diseases. And in doing that, that we can join others in the Western world in this drive for personalized healthcare for non-communicable diseases. Distinguished ladies and gentlemen, I want to say a big thank you and to say that if there are questions, I'm open so that we can answer those questions. Thank you.
So thank you so much, Ma. We really appreciate, you taking out time to come and give us this very lucid and well-delivered lecture. We appreciate you so much. So it's time for question and answer. Professor Aderonke Samuel has presented the role, the accuracy of biomarkers for proper diagnosis. I'll just quickly summarize what she said. She has talked about biomarkers, how they are very important in diagnosis and proper diagnosis of many disease conditions. And she talks about how to ensure accuracy of these biomarkers. She talked about analytical accuracy, clinical accuracy, and also she talked about this. This helps to determine sensitivity, specificity, predictive value, and the ROC curve. She talked about what sensitivity is, what specificity is, what likelihood ratio is. She also talked about the ROC curve, and she mentioned when the area under the curve is 0.1, 0.0, that is a perfect test, and if it's 0.5, that is a useless test when you are using the ROC curve to determine the area under the curve, whether what you got is perfect or is not worth it. So she also went further to talk about what she has been doing in University of Lagos, in the Department of Biochemistry in terms of genomic studies, and she also talked about the partnership she has with Professor Olufemi Fasomade. So at this point, we want to entertain questions, clarification on what Professor Aderonke Samuel has presented. Thank you very much. So we entertain question. If you have question and you want to speak, you can raise up your electronic hand. You'll be called upon, or you can drop your comments on the comment section. Thank you so much for your patience as you are in the meeting. So questions, answers, comments, or contribution. Thank you. So we are with questions, comments. Any questions, any comment, any clarification on what Prof has presented so far? Okay. So in the absence of no question or comments, I don't know whether there's any other comments, any electronic hand raised, any comments. I can't see any comment on the chat box yet. Any comment, any clarification? So I think so we will proceed to the fourth presentation. Okay, we want to appreciate Professor Aderonke Samuel. Thank you very much, ma, for the very excellent and lucid presentation. We are grateful. Thank you, ma. So I think we'll move to the next presentation, and this presentation will be taken by Dr. Ahmed Ninolowo. Is going to be taking the role of interventional radiology in endocrinology. The role of interventional radiology in endocrinology. I'll quickly give a short citation of Dr. Ahmed Ninolowo. So Dr. Ahmed Ninolowo is a US-trained, double-boarded diagnostic, vascular, and interventional radiologist who completed his training at the prestigious University of Pennsylvania and is the first US-trained physician to offer the full spectrum of interventional radiology services in Nigeria. He obtained his medical degree at the University of Illinois and graduated at the top of his class with honors, that is Alpha Omega Alpha. He then went on to do his residency in diagnostic radiology at the University of Maryland Medical Center. He started his practice as in IDOC, Nigeria in 2018, and has since moved his practice primarily to Nigeria to deliver interventional radiology care to Nigeria and sub-Saharan Africa patients. Dr. Ninolowo has pioneered many procedures in Nigeria and in West Africa, including the first transjugular portosystemic shunt, part of the team for the first endovascular brain aneurysm coiling, the first mechanical thrombectomy for stroke, the first prostate artery embolization, the first endovascular repair of aortic aneurysm, the first scrotal varicocele embolization, to just name a few. Currently, he even has a lot of procedures to do today, but he's just taking out his time to be part of this meeting. He's well known and passionate for treatment of uterine fibroid with a minimal invasive procedure called uterine fibroid embolization. Dr. Ninolowo has been at the forefront of creating sustainability for the field of interventional radiology in Nigeria, with a focus on training physicians, primarily from the public sector, who can then provide services to low-income patients in these public settings. He graduated his first fellow in June 2024, who is now back practicing at the University College Hospital Ibadan and has grown a local practice. He's the co-founder and CEO of Accurate Radiology, the first Nigerian tele-radiology company providing remote tele-radiology services to many hospitals in West Africa and market leader in Nigeria. This has allowed brain gain for Nigerian health sector, as many radiologists all over the world or the ones that have left Nigeria can now provide the tele-radiology services to Nigerian patients while still in abroad. He has a passion for improving access to radiology services and minimal invasive therapies, and continues to preserve the quest to make this a reality and readily available in Nigerian population. Please join me as we welcome Dr. Ahmed Ninolowo to take the role of interventional radiology in Nigeria. Dr. Ahmed Ninolowo, sir, you are welcome.
You think that's screen guarded?
Hello, good morning, everyone. My name is Dr. Ahmed Ninolowo. I'm a
Also, I'm
what I want to talk to you about today is the role of interventional radiology in endocrine disorder and what we could offer in interventional radiology. It's quite a broad topic, so I'll focus on some of the aspects of endocrinology and radiology that come together that are quite important. So I think it's important to first talk about what interventional radiology is. It's a medical subspecialty which we utilize minimally invasive image-guided techniques to both diagnose and treat diseases. And the goal is to use the least invasive techniques in order to minimize risk and also improve healthcare outcomes. There's also another arm of interventional radiology now called interventional oncology, which is now well established as the fourth pillar of oncology after radiation oncology, medical oncology, and surgical oncology. And basically, with interventional oncology, our focus is on interventions that both diagnose and treat cancerous conditions. What group of patients do we treat? The simple answer is all patients, because interventional radiology basically participates in the care of basically nearly every patient that's taken care of by other specialties. So we get to collaborate with physicians across specialties to both diagnose and treat primary diseases and also address medical or surgical complications. In some cases, in most hospitals in the West, we're really known as the surgeon's best friend. So the scope of interventional radiology is quite wide. As I said, we collaborate with doctors across all fields of medicine. We do interventions, including gynecological interventions, neuro interventions, lymphatic interventions. If there's a way to use imaging to basically to tackle a condition or to diagnose a condition, we're typically there. So we're quite vast in our skills. And when there's a problem that it's difficult to solve, you typically will call an interventional radiologist, and we're able to help solve that problem in a lot of cases, or think outside of the box to help solve that case. So in endocrine disorders, we typically would deal with disorders involving the hormone-producing glands, the thyroid gland, the parathyroid, adrenal gland, pancreas, and the gonads. And many of these organs, or many disorders in these organs, usually will require medical or surgical management. But in a lot of cases, we could offer alternative therapies to both medical and surgical management, or in patients who are poor surgical candidates, we could offer alternative therapies in those patients. And the advantage of IR is most of our therapies are targeted therapies. We reduce morbidity, and patients get faster to recovery. And I'll talk about some of these modalities that we do. So we do participate in a lot of diagnostic applications in the setting of endocrinology. I think the thyroid gland is one where we do a lot of thyroid fine needle aspirations. The advantage for IR doing fine needle aspirations is that we do use it ultrasound guidance, so we're very precise in targeting nodules, both in the thyroid and parathyroid glands and parathyroid nodules that can be found on ultrasound or cross-sectional images. We could also perform core needle biopsies, sometimes in the thyroid gland, sometimes in the adrenal gland, or other endocrine organs such as the pancreas. We also do fancy things like something called selective venous sampling, and I'll talk about this especially in the adrenal gland. So in patients with Cushing's disease, we could do inferior petrosal sinus sampling, where we put a catheter all the way into the inferior petrosal sinus, draining the vein, and basically get samples of cortisol from that to basically diagnose Cushing's disease in some cases. And I'll talk a little bit more about adrenal venous sampling, which is something we do quite commonly. So in adrenal disorders, when patients have primary aldosteronism, you're thinking about, if the primary aldosteronism is from one adrenal gland versus the other. In some patients will have both glands having nodules in them, so you're really confused as to which one is producing the aldosterone. In a lot of these cases, you typically do not want to take out both adrenal glands, right? And because if both adrenal glands are problematic, those patients would require lifelong, basically, targeted medical therapy. So in IR, we do a procedure called adrenal venous sampling. And what we're doing with that is we're essentially getting a catheter from the common femoral vein in the groin and directing that catheter very selectively into the adrenal veins on both sides. And this procedure is actually quite complex in getting into the adrenal vein. But most importantly, the coordination it takes to do this procedure is quite complex, because we need to get baseline samples every 5 minutes, about every 5 minutes before. We then give the patient concentropin, which is a synthetic hormone that stimulates the adrenal glands and allows for assessment of their function. After giving the concentropin, we then would get samples between 5 and 30 minutes after concentration injections. And what we're looking for is basically stimulation of the adrenal gland in those settings. And if you can prove that one adrenal gland is producing and the other is not producing, then that patient can get curative surgical therapy where they do an adrenalectomy on one side and leave the adrenal gland on the other side alone. And that patient doesn't have to be on long-term medical therapy. I also talk about the alternatives to surgery in this situation for patients who are not surgical candidates. We also have a lot of therapeutic roles in endocrinology. We do things from ablation, which could be radiofrequency ablation, to microwave ablation. These are techniques that we talk about. We could also do ablation. We do embolization of tumors, including embolization of the thyroid gland, which I will talk about, hyperfunctioning glands, embolization of tumors in endocrine glands in patients who are either poor surgical candidates or having preoperative embolization prior to surgery. We also do drainage of collections such as thyroid cysts, cysts in the parathyroid gland, sometimes cysts in the pancreas. Some patients could have a cyst in the adrenal gland, which can be drained if needed. We also do selective catheter-directed therapy, and basically this is basically the same thing as embolization, where we're embolizing things like the thyroid gland, and in some patients who may have like neuroendocrine tumors of the pancreas or neuroendocrine tumors somewhere else in the body that is metastasized to the liver and have neuroendocrine syndrome, we can perform in those patients targeted bland embolization of the liver, also called TAE, transarterial embolization, using bland particles of the liver basically to devascularize those hypervascular tumors. And these patients who have neuroendocrine syndrome can get better with embolization in a lot of cases. We also treat the chronic sequelae of endocrine disorders, which is something I would focus on a little bit, which is diabetes and diabetic foot and what our role is in that. So first of all, talking about therapeutic ablative techniques, so the modalities we would typically use currently are either radiofrequency ablation or microwave ablation. We typically just use microwave ablation for everything now because it's much simpler. In a lot of cases, you could use one probe, and the availability is much better than RFA. So we do have microwave ablation here in Nigeria. We've had it for about 7 years. We've performed microwave ablation in a lot of different applications and a lot of different patients for different reasons, some of which I will talk about. Action in microwave ablation, again, it's a heat-based technique, and you're basically causing heat-induced coagulative necrosis and gradual shrinkage of whatever tumor you burn with the spin. And basically the nodule size, the tumor size would decrease over time, over a month. So these are examples of ablation, microwave ablation for metastatic disease in a patient who had metastatic disease to the adrenal gland and basically had solitary metastases. This is a microwave ablation probe. This is a convenient probe coming in posteriorly and going directly into the adrenal gland. And a lot of these cases, ablating the adrenal gland is a big deal because the patient could go into an hormonal storm when you're doing this. So you typically would need good anesthesiology to ensure that the patient doesn't go into a storm situation during the procedure. Patients that are poor surgical candidates can also get ablative techniques in disease. You could do preoperative embolization in patients that have hypervascular metastasis in the adrenal gland, also for patients who are going to surgery. Thyroid nodules, moving on, so thyroid nodules are quite common prevalence on ultrasound. If you scan most patients, 60%. But majority of these are typically benign, about 5 to 15% are malignant. And as we know, surgery is a traditional treatment for symptomatic or growing nodules. But more and more over the last few years, image-guided ablation has gained traction as a lot of patients can get this treatment done as an outpatient treatment, very safely, very targeted, and try to avoid surgery in a lot of these patients. And again, you know, the goal of ablation is to destroy the tissue, but the advantage is that we will preserve normal thyroid function and anatomy in a lot of cases, and a lot of this thyroid has an adjunct. So basically, this is just showing a microwave probe, again, going into a hot nodule in the thyroid gland, which I would demonstrate a bit further. But indications for thyroid ablation include benign nodules that are causing symptoms such as dysphagia, voice changes, neck discomfort, cosmetic changes. And we would typically make sure that an FNA is done in these cases to make sure that we have a benign cytology before going for ablation in these cases. When a nodule is cystic or predominantly cystic, we would typically ablate this first, and then these patients may also undergo ablation. However, we would typically start with ethanol ablation in these cases. Patients who have autonomously functioning thyroid nodules can also get thyroid ablation. And as I said, the advantage of this is it's targeted therapy. You could preserve thyroid function, and you could still reach the goal of decreasing function of this hyperfunctioning nodule in a lot of cases. In selected malignant or recurring cases, patients that have things like low-risk papillary thyroid microadenomas, microcarcinomas, can also get ablation if they're inoperable or they're refusing surgery. And as we know, a lot of patients are trying to move more and more towards minimally invasive techniques, but we are also very cognizant that we shouldn't be doing ablative techniques or do minimally invasive techniques on patients that can get curative therapies such as surgery, especially if you have a suspicious of proven high-grade malignancy that requires surgery. So those typically will go to surgery and not come to ablation. So how do we do thyroid ablation? So the technique is pretty simple, actually. So if you look at the anatomy of the neck, this is the trachea here. This is the isthmus of the thyroid gland. This is the right thyroid lobe. This is left thyroid lobe in this case. And you can see in this case, there's a nodule here on this thyroid. And the vessels are typically just lateral to the thyroid gland. So we would typically, in these cases, start by coming in and infiltrate around the thyroid or around the nodule that we're trying to ablate. We would infiltrate that with a mixture of lidocaine and saline, basically, to cause hydrodissection around the thyroid gland, because you're also trying to protect all of the structures around the thyroid gland. And then once we're done with that, with thyroid ablation, we would typically use a 16 gauge needle to ablate, and we use this something called a moving shot technique, where you basically ablate different zones within the nodule. So in this case, you could see this numbering that's done here: 1, 2, 3, 4, 5, 6, 7, and you basically continue. So in this case, we would come in transisthmic, basically get the ablation probe here, burn in that area, and then we're doing very small area burns, only about 5 millimeters to about 8 millimeters at a time. And you're burning, and you're basically coming through the moving shot technique to the third zone, and then you go back down and start burning until you've covered the entire lesion. And most patients can go home for about 1 to 2 hours after the procedure is done, and we will typically then follow them up at 1, 3, 6, and 12 months after the procedure. This is an example of a patient who underwent thyroid ablation for a large nodule and a large goiter. And you could see months later, you could see that the neck size is much smaller. And we would typically say we would get a volume reduction, somewhere between 50 to 90% over the next 6 to 12 months. Again, we counsel patients appropriately that this is a gradual process, right? And the goal is to improve symptoms and also cosmetic improvement in majority of patients. There are low recurrence rates if we have adequate coverage in these areas, and thyroid function is typically preserved in a lot of these patients. Complications are rare. However, patients post-thyroid ablation can get pain and swelling. Some patients cannot go at hematoma if a small vessel is traversed during the ablation. Some patients will have transient voice changes due to ablation of the recurrent laryngeal nerve. I do always warn my patients, however, that I do expect some voice changes right after the procedure, because we've infiltrated that area with lidocaine, and most patients by 2 days or so, those voice changes will get better. We still haven't had a patient who has had a long-lasting injury to the recurrent laryngeal nerve. Skin burns are rare. Again, when you properly do hydrodissection along the skin and along the planes of where you're ablating, you would rarely get skin burns in these patients. Again, the advantages of this technique is that, it's an outpatient procedure. In a lot of cases, no general anesthesia is involved. You preserve thyroid function, you avoid surgical scars. I mean, I'm sure you've seen a lot of patients who have undergone surgical thyroidectomy, and you see this large scar on their neck. It's like basically a necklace that they have to wear all the time. The recovery time is short, and most patients can go back to work by the next day, and you can repeat it if you don't get the desired techniques. One other technique in the thyroid realm that we've done in Nigeria recently is thyroid artery embolization. And again, this typically would be done in patients who have large thyroid goiters who do not want surgery, or patients who have a focal large nodule who have cosmetic concerns from that large thyroid nodule. And again, this is a minimally invasive IR technique where we go basically to occlude blood supply to the thyroid gland. And the benefits of this are targeted, there's a targeted therapy, reduced surgical risk. You get rapid symptom control in hyperparathyroidism for patients with mass effect. And I have seen this in about 2 or 3 days or so. Patients already feel a significant decrease in the mass effect from these nodules following ablation. The rationale for TAE is that the thyroid gland is highly vascular. We understand the vascular anatomy to the thyroid gland. There are typically a few vessels, one of which I was showing on my last slide. That vessel was the inferior thyroidal artery. Here I'm showing the suprathyroidal artery, where we've come from the groin, and we've come basically to the area of the carotid bifurcation, and we've catheterized the suprathyroidal artery. And as you can see, this is a very large artery here now feeding the thyroid inferiorly. Following identification of that artery, we would then typically put in a microcatheter, which is a very tiny catheter that goes much deeper into this vessel in order to deliver particles into this vessel. And the reason we're going much deeper into the vessel is, remember that what's on top of us here is the brain. If we start to inject particles from this location, some of those particles can reflux up into the brain, and basically you're giving the patient a stroke. And again, this is an elective procedure, which should be relatively risk-free. So you really want to make sure that you're using appropriate technique to do this. And the goal of this is to reduce the gland size and hormone production in hyperfunctioning states, shrink large nodules or goiters to relieve compressive symptoms. In patients who have bleeding and are going to surgery, will reduce intraoperative bleeding in selected cases. And especially, this is especially very valuable when surgery is contraindicated of patients who do not want to have surgery. So the indications for thyroid artery embolization include benign conditions such as large multinodular goiters with compressive symptoms, patients who have toxic multinodular goiters or a toxic adenoma in poor candidates can also have embolization or ablation, and again, preoperative devascularization for patients who have highly vascular goiters. We would rarely do embolization in malignant conditions, but patients who are selected as very poor surgical candidates can have, or who have unresectable tumors can have embolization as a palliation technique. And again, we can do preoperative embolization in patients who are going to surgery. And what's the technique for this? So the technique would typically be to access either the common femoral artery in the groin, which is most common because you're going into both sides of the neck, or access the radial artery in the wrist and basically put in a catheter on the X-ray. And the anatomy to the thyroid gland is very standard in that on both sides you get basically the superior thyroidal artery that comes in the region of the carotid bifurcation, and also you do have the inferior thyroidal artery that would typically come up the subclavian artery. And when we're doing thyroid embolization, I would typically look at cross-sectional imaging and see what part of the gland is the smallest. And typically, whatever part of the gland is the smallest, I would try to preserve. So essentially, if the inferior side of the inferior pole of the left thyroid gland is the smallest, I would basically then choose to embolize the superior thyroidal artery on both sides, and then the inferior thyroidal artery on the right side, and leave the left side alone, because you really don't want to get the patient going into hypothyroidism after doing this. Post-procedure, we do expect patients to have a bit of pain. Some patients don't have pain, but some patients may have a bit of neck swelling from the inflammation. The biggest thing we're looking for after the procedure is a thyroid storm. And basically, that's a significant release in thyroid hormones over a short period of time. When this is going to happen, it's going to happen typically within a few hours to 24 hours after the procedure. So I would typically keep my patients in the hospital overnight to monitor them on the telemetry to make sure that we're not getting high heart rates. And if that does happen, we then have control with medications that are available in hospital, including thyroid binding medications and beta blockers in order to control a thyroid storm. The outcomes of this procedure are quite good. A lot of patients will get symptom relief mass effect and dyspnea and dysphagia. We've done a parathyroid embolization on a patient who had been in the hospital, 80-something-year-old woman who had been in the hospital for about 6 months with high calcium levels and mass effect from this big parathyroid lesion, and basically was able to go home 3 days after embolization was done after being in the hospital for over 6 months. For patients that have hyperfunctioning glands, they could have decreased thyroid hormone levels within days to weeks. There's usually a reduction in the gland volume over weeks to months, and then decrease of intraoperative bleeding when used operatively in patients. As I said, the biggest thing we're thinking about post-procedure as far as complications is looking at thyroid storm. We typically would be ready to treat that in the hospital and make sure the medications are available if we encounter that. And then with non-target embolization, as I said, if you don't know what you're doing and putting particles in the wrong place, you can cause things like a stroke. If you over-embolize in the thyroid artery, you could cause a laryngeal nerve palsy or esophageal ischemia if the vessels are anastomosing with the same vessels that feed the esophagus. So you do have to understand the anatomy in this area quite well, and then not over-treat or under-treat. So moving on to diabetic foot. A lot of endocrinologists do see patients that have diabetes. And we know diabetic foot disease is a major cause of morbidity and mortality and amputation in patients with diabetes. And the pathophysiology is essentially patients having peripheral vascular disease with narrowing and occlusion of vessels. These are most commonly vessels below the knee in these patients. They will typically have neuropathy at the same time, and essentially when they have ulcerations, they will typically have infection and impaired healing because they have neuropathy and because they have poor blood supply to this area. So interventional radiology plays a significant role, a critical role in critical limb ischemia, basically salvage the foot in a lot of these patients. And the goal basically to decrease amputations. And we know that diabetes and the diabetic foot has a global impact. And we know that about 25% of patients with diabetes will develop foot ulcer, and amputation risk in these patients is quite high, as diabetes accounts for about 50 to 70% of non-traumatic limb amputations. There's a poor prognosis, a high 5-year mortality post-amputation in a lot of these patients. So if we can salvage the foot, we will try to salvage the foot and prevent amputation at all costs. And this is a major focus in the West in making sure that these patients could keep their limbs. What role do we play in interventional radiology in these patients? We offer non-invasive vascular imaging and interpretation of those vascular imaging. One thing I have seen generally in Nigeria is lack of understanding of the information we need from CT angiograms or MR angiograms, or even duplex ultrasounds for a lot of these patients, because the information is quite critical in how we treat these patients. So having somebody that understands the treatment side, also looking at the imaging, is typically helpful. We offer a lot of different modalities in the treatment of these patients, which will include angioplasty, stenting, atherectomies. In patients that come in with acute limb ischemia, we could also thrombolize this. So there are several techniques we have to treat these patients. So angioplasty is the most common, especially patients that have symptoms or disease below the knee, where you have all these very tiny vessels, the anterior tibial, the posterior tibial artery, the peroneal artery. When they are occluded, you have to use very tiny wires and catheters to find your way through these vessels all the way into the foot. Because the goal in basically what we've shown is that if you could open a one vessel run up to the foot, you could decrease amputations by up to 50%, which means if there's one vessel going to the pedal arch and the pedal arch is open, a lot of those patients will heal their ulcers. And that's the goal, is basically to open more than one vessel if possible. If we can't open more than one vessel, then we would open one vessel. It's very rare to do stenting below the knee. Some patients do get stents for resistant lesions below the knee, but very rare. We would typically more likely use stents in the SFA and the popliteal artery in most cases. We also have all these atherectomy devices now that are endovascular and can be used basically to shave off plaque in a lot of these patients. These are quite expensive. These are things that we do not have available in Nigeria, but we certainly have angioplasty and stenting readily available. As I said, the goal is basically to make sure that we can open up a pedal arch. So we will do everything if we're coming from the top and we cannot get into the vessel from the top. We would then, in a lot of these patients, access those vessels from the foot and basically do something called a rendezvous, or something called safari technique, where we're going from the top, we're going from the bottom, and basically use that as a way to put a balloon in, basically to stretch out these vessels. And, I would say these cases with diabetes are probably not my favorite things to do because it is very unpredictable what you're going to get into as far as opening the vessels. Sometimes it's easy. Sometimes you can be there for 4 or 5 hours chasing one tibial artery to get it open. But the most important thing in this patient is a multidisciplinary approach, where there's, endocrinology for glycemic control. There's a podiatrist or a wound care person that's there for ulcer management. We have infectious disease to treat infections. We would, in IR or vascular surgery, will perform revascularization. And then you also need rehabilitation for patients to understand the importance of proper footwear, physical therapy. So these things has to come together in order to get good results in diabetic foot patients. Unfortunately, what I've seen in Nigeria is that our care is typically very disjointed in a lot of cases. And it's very hard to get this multidisciplinary approach. But I must say, over the years, we're getting better and better and making sure that we understand everyone that needs to come into a team to treat a patient in order to achieve success. And we have had successful stories with diabetic foot treating patients with orthopedic surgery and wound care physicians. I would say that we've not really worked with a lot of endocrinologists. Patients have seen endocrinologists in the background. We've referred patients to endocrinologists, but actually having this wholesome team-based approach, we've not seen a lot of. And we typically don't have a lot of endocrinologists in Nigeria anyways. We have a high technical success rate in opening up these vessels, over 85%. Limb salvage rates could be greater than 70% at 1 year if there's prompt intervention. And I cannot emphasize enough on prompt intervention. Unfortunately, a lot of patients that are sent to our service in Nigeria already have gangrene, and basically there's no reversal of that. And we're very selective now on which patients we treat and which patients we don't treat. Because as you know, most patients in Nigeria would spend hard-earned cash for a lot of these procedures. So I really don't want to waste the patient's time. However, we do have patients that are very motivated, both in getting revascularization done and motivated in wound care after, to make sure that they do get the best results. And we have seen some dramatic changes in these patients that are quite motivated. We can do repeat interventions if we need to in the future in patients who develop restenosis. But the goal is, if there's blood vessels reaching an ulceration and you could do a debridement for those ulcerations, they will heal as long as there's vascular supply. So in conclusion, interventional radiology is central to modern diabetic foot management through limb salvage and endovascular therapy. The success really depends on early detection. I cannot emphasize enough how important it is to have early detection and having multidisciplinary care and long-term follow-up. Patients that are followed long-term by wound care physicians and very closely, doing the proper dressings and being sent back to us immediately when they see changes that are not going in the right direction in order to do procedures that would then improve limb salvage. But again, the goal is always to salvage the limbs, save the patient's life, save the patient's quality of life, and decrease mortality rates. And because when these patients get amputations, mortality rate significantly increases. We also participate in other embolization techniques. As I said, we would embolize tumors such as pheochromocytomas, targeted therapies in the liver, or neuroendocrine disease. So our spectrum is quite wide. It's very difficult to talk about all of it in one lecture. Our spectrum is very, very wide. I talked about the parathyroid gland before. We can perform microwave ablation for hyperfunctioning adenomas. We can perform transarterial embolization for large adenomas in non-surgical candidates. And we have done this successfully with improved results. So in conclusion, interventional radiology plays a growing role in the diagnosis and minimally invasive treatment of endocrine disorders. We offer safe and effective alternatives or adjuncts to surgery in a lot of cases. But most importantly, multidisciplinary collaboration between endocrinology and surgery is essential for optimal outcomes, and also making sure that we're collaborating with interventional radiologists, asking about the possibility of minimally invasive options, even when we think there are no options at all. This is our team in Lagos. We will continue to grow over time. And this was an article that was published in 2019. I think this was the first time we did a safari in Nigeria, where we went from top and we went from below and connected an artery from the foot and from the groin, and this was quite an accomplishment at that time. We've gone on to do many of these procedures since then to get in a lot of patients to have proper limb salvage. Thank you very much.
So thank you, sir, Dr. Ahmed Ninolo, for that well-delivered, apt and presentation. So I will just quickly give a summary of what he has said so far before we entertain questions and comments. So Dr. Ahmed Ninolo has spoken on the need for interventional radiology in all patients. He talked about the multidisciplinary collaboration they are always involving in the management of a patient. And he also highlighted the scope of interventional radiology. It was really, really long, and he highlighted all the scope. So now to cone it down to endocrine disorder, he talked about the role of interventional radiology in endocrine disorder involving the thyroid gland, parathyroid gland, adrenal gland, pancreatic gland, and the gonads. So looking at the adrenal gland, he talked about the adrenal vein sampling that can be done in primary aldosteronism to actually know, especially when all the tests you've done, all the endocrine, all the tests you've done have shown that it's not certain where the excess aldosterone is coming from. Is it from the right or the left? And you will have to go further into adrenal vein sampling to make a diagnosis and treat this patient appropriately. So it's something they can easily do. And also talking about embolization of tumors of endocrine gland, like the pheochromocytoma. We talked about drainage of thyroid cysts. So all our patients doesn't necessarily have to be under the knife. So that's because there's a paradigm shift in management. Everything is not open surgery. So we've moved beyond that, and we need to start imbibing what obtains even in the international level. So talking about embolization of drainage of thyroid cyst, pancreatic cyst, also talking about selective catheter-directed therapy for thyroid embolization. It talked about treatment of diabetic foot. We don't have to amputate all foot. There are some minimally invasive therapy that can preserve limb salvage surgeries, limb salvage procedures, so they can do angioplasty, stenting, atherectomy. And also to make a proper diagnosis of peripheral arterial disease, there might be need for non-invasive vascular imaging, So he also moved on to ablation therapy. which is an heat-induced coagulation necrosis. It talked about thyroid nodules, image-guided ablation. So all our thyroid patients with goiter doesn't necessarily have to be under the knife. So using minimally invasive alternative, we can actually achieve this, and the patient is fine. So they don't have a scar. So there's also thyroid embolization via thyroid embolization with large nodules, image-guided ablation, and the like. So he has spoken extensively on this, and there's a lot of paradigm shifts, and we need to start, moving beyond open surgery for all our endocrine disorders. So thank you so much, sir, Dr. Ahmed Ninolowo, for that excellent presentation. At this point, we'll now entertain questions, comments, clarification. If you have a question and you want to speak, you can raise your electronic hand and you'll be allowed to speak. But if you know you are not speaking, please kindly mute your mic so that there won't be noise on the background. And also, if you want to drop your comment, you can drop your comment. We'll also attend to those comments as dropped in the chat box. I can see a comment already from Dr. Diolu. She says, "Thank you for your presentation, sir. I would like to ask if the procedure of embolization can be repeated in disease recurrence, and if yes, how many are allowed?" So that's the first question for Dr. Ahmed Ninolowo. So I think this is the first question we are receiving. Maybe till we receive other question. Okay, there's another question from Dr. Isiawe. He's saying, "Thank you, Dr. Ninolowo. Please, do you see only private clients in Nigeria, or do you attend to clients accessing healthcare through local health insurance company?" So that's another question for our distinguished speaker. And also, Dr. Ifeoma said, "Thank you, sir, for your presentation." So I think we have two questions already at the chat box. And Dr. Ahmed Ninolowo, sir, you can please attend to those questions while we await more comments. Thank you, sir.
Good morning, everyone, and thanks for having me. Sorry, I'm actually kind of in an emergency situation, so I'm only going to answer two questions and I have to go. I think the first question was about repeated procedures for doing thyroid embolization. Yeah, you can repeat it if a patient has a recurrence. Interestingly, I've never had to repeat one before. But again, we've not been doing thyroid embolization very long. This is a technique that's only been around for about 8 years or so, but it's gaining a lot of traction. And I've not seen a patient recur enough that's needed a repeat so far. And the other question was, do I treat HMO patients in Nigeria? Yes, I do treat a lot of HMO patients in Nigeria, and it just depends. There's a lot of complex problems that, even if it's a local HMO patient, they'd still rather come to us rather than travel outside of the country, and the HMOs would work with us. As a matter of fact, I'm in Abuja right now to treat an HMO patient with a brain aneurysm. And that's why I have this emergency. But yes, we treat all kinds of patients, private or HMO.
Okay, thank you so much, sir, for taking out time. I know you are very busy. I know you've also shared your schedule. Thank you so much, sir. Dr. Olayinka says, "Thank you for the brainstorming presentation, sir." So we really appreciate you, sir. Thank you so much, sir. Yes.
No, radio.
Yes, sir.
All right, thank you, everyone. I do have to go. If there are any more questions, please email me, and I'm happy to answer them.
Okay, sir. Okay, sir. Thank you, sir. Thank you. So at this point, we'll move to the fifth presentation before we go on tea break for 30 minutes. After this presentation, we'll be going on a 30 minutes tea break, and we are resuming exactly 30 minutes to continue this array of presentation because the speakers are ready to dish out all the necessary stuffs we need for our clinical practice. So now, to take us further in this array of presentation, we are moving to the presentation by Mrs. Olajumoke Osunsoya. She's going to talk about the medical nutritional therapy, which is very paramount in an endocrine disorder care for our diabetes patients, many patients. So in terms of medical nutrition therapy, it can never be on the said. So now I will just quickly take the bio sketch of Mrs. Olajumoke Osunsoya. Mrs. Olajumoke Osunsoya, how DN MPH is a trailblazing registered dietitian, nutritionist, and founder of Carrier Diet, dedicated to advancing nutrition and public health in Nigeria. With over 8 years of clinical expertise, she holds a BSc in Nutrition and Dietetics from the University of Agriculture, Abeokuta, and a MPH in Public Health Nutrition from University of Ibadan. Olajumoke is also internationally certified as a diabetes educator and was the first dietitian in Nigerian private sector to achieve the Royal Young Leadership Forum Award through the Carrier Diet Clinic. Olajumoke provides evidence-based, personalized care for conditions like obesity, hypertension, dyslipidemia, diabetes, chronic kidney disease. As the first diet clinic in Nigeria registered under the HEFMAA, Carrier Diet Clinic partners with 9 HMOs, over 15 hospitals, and various corporations offering accessible subsidized nutritional services in Nigeria. In the corporate wellness sector, she has led workshops for top firms such as Nigerian Breweries, IHS Towers, Coca-Cola. Carrier Diet is also a key player in professional development, mentoring dietitians to expand access to quality nutrition in Nigeria. Over the past 4 years, Carrier Diet Clinic has supported over 10,000 clients in achieving their health goals, boasting an 85% success rate. Join me in welcoming this very distinguished dietitian, Mrs. Olajumoke Osunsoya, as she presents medical nutritional therapy in endocrine disorder and other medical problems. Thank you so much.
Good day, everyone. It's both a privilege and a profound honor to present to leaders, clinicians, and pioneers in the field of endocrinology and metabolism in Nigeria. On behalf of the entire team at Carrier Diet Clinic, I want to express our deepest gratitude to the
Sorry for the glitches, we'll soon be back.
and Metabolism Society.
So sorry, we are working on it. Yeah, thank you.
Of Nigeria-EMSON for this kind invitation to speak on a topic that sits at the very heart of effective diabetes care in Nigeria. Thank you so much for the opportunity. And today, you can see on the screen that my name is Olajumoke Osunsoya. I'm a registered dietitian and the lead dietitian at Carrier Diet Clinic. I also have my master's in public health. And today I'm going to be presenting on medical nutrition therapy in diabetes care. And we'll be touching on the startling statistics of prediabetes and diabetes, guidelines on medical nutrition therapy, core principles and evidence of MNT in diabetes care, evidence on the effectiveness of MNT, carbohydrates and other macronutrient management, evidence-based supplement, herbs and spices, the interprofessional approach, spotlighting the dietitian's role on the diabetes care team, and lastly, conclusion and key takeaways. Now let's start with the startling figures of diabetes. According to the International Diabetes Federation report in 2024, about 589 million adults between the age of 20 and 79 are actually living with diabetes globally. This is 1 in 9 of adult population. And it's projected to reach 853 million people in 2050, if nothing is done about it. Also, 4 in 5 adults with this diabetes condition live in low and middle income countries, Nigeria inclusive. Also, at the same International Diabetes Federation, in 2021, it was estimated that 9.1% of adults, which is equivalent of 464 million people, had impaired glucose tolerance, and 5.8%, which is equivalent to 298 million, had impaired fasting glucose. Now let's bring it down to Nigeria. A meta-analysis by Olamoyekun et al., incorporating 60 studies, discovered that there's a pooled prevalence of 7%. And this is nearly double the estimate by IDF, which put it as 3.7. And if you look at the charts on the left side of the screen, you will see that the highest prevalence was found in South-South. This is about 11.35%. And the lowest prevalence was found in Northeast, which is about 4.45%. And if there's any other thing to notice on this chart is that we have more studies from areas of higher prevalence and low studies from areas of low prevalence. So for instance, in South-South, we have 9 studies from South-South, and in Northeast, we have only 2 studies. So it is possible that the lower prevalence in certain geographical area in Nigeria is due to fewer numbers of studies carried out there. Now, let's quickly meet Mr. Jerry. Of course, that is not his name. His age is 35, and his height is 6 feet, that's about 1.83 meters, weight 107 kg, BMI of 31.9, which is obesity class 1. This patient has a medical history of diabetes, which was recently diagnosed, hypercholesterolemia, gastric ulcer with GRD. Our goal is weight loss, improve lipid profile, manage prediabetes, and prevent GERD symptoms. Now, during consultation, this patient confided in us that he was confused and he had to use AI to generate a diet plan for himself. Now, while following this diet plan, he found out that most of the food on the diet plan are not culturally based. They are not Nigerian food. So he was still following it, he was frustrated. He found out about us and consulted. During the consultation, we were able to tailor the diet plan to the cultural foods available here in Nigeria. And as you can see, of course, after our assessment, we always have nutrition diagnosis. And for this patient, we have uncontrolled blood sugar and lipid profile related to a disconnect between culturally unfamiliar meal plan and personal food preferences, as evidenced by patient's frustration, recent diagnosis of prediabetes and hypercholesterolemia, and BMI of 31.9. So most times, our nutritional diagnosis is always different from the medical diagnosis. Nutrition diagnosis is based on the nutrition assessments, and after 1 month of the personalized nutrition care plan developed for these patients, the patient was able to adhere to the diet plan because it is now culturally adapted, and his blood sugar was now consistently below 100 mg per DL. He was also able to lose 5 kg, and patient was, of course, happy. There's improvement in the GERD and the gastric ulcer symptoms. This is a summary of medical nutrition therapy. Now, let us talk about the definition of medical nutrition therapy. Medical nutrition therapy, according to the Academy of Nutrition and Dietetics, is an evidence-based medical approach to treat medical conditions and their associated symptoms. The use of specifically tailored diet devised and monitored by a registered dietitian. To explain the definition further, let's look at the principles of medical nutrition therapy. The first one is a core concept. It's a fact that it is evidence-based. It is evidence-based therapeutic approach to treating medical conditions through a specifically tailored dietary intervention, right? So most of the strategies used in medical nutrition therapy are usually rooted in science. rooted in evidence-based findings from studies, from systematic reviews, from the highest level of evidence from research studies, right? So the provider, the second principle is that the provider has to be a registered dietitian or a qualified healthcare professional with advanced training in nutrition, right? And the process includes assessment of nutritional status, diagnosis of nutrition-related problems, intervention, monitoring and evaluation of progress. From the short story that I shared with you, I mentioned nutritional assessments, the fact that this patient was assessed. When it comes to nutritional assessment, we're talking about anthropometric assessment, biochemical assessment, which is a laboratory result assessment, clinical assessments, dietary assessment, and then the environmental factor. What are the cultural beliefs that are attached to these patients that could actually influence their diet and lifestyle choices, right? Before coming up with nutrition diagnosis, and this nutritional diagnosis is what will now be targeted at for intervention. Have in mind that for intervention, our major intervention as dietitians is personalized nutritional therapy or counseling. Most times, supplements is the second, basically the second at the second place. The first line is personalized nutrition therapy and counseling. And we also have monitoring and evaluation. This is always in structured follow-ups. So we meet patients sometimes every week. When the patient feels better, we move on to every 2 weeks. And when the patient is seeing tremendous results, we can now move on to once every month. And the goal is to achieve specific metabolic and health outcomes, such as the HbA1c, blood pressure, lipid profile, and quality of life. Now, let's move on to guidelines. Guidelines for medical nutrition therapy for the prevention of type 2 diabetes, which is pre-diabetes. So guidelines for managing pre-diabetes. On the right side of the screen, you could see my references. The first one is the American Diabetes Association Standards of Care in Diabetes. The second one is the Academy of Nutrition and Dietetics. And the third one is the International Diabetes Federation Guidelines. And the fourth one is Diabetes Prevention for DPP Research Group. These are generally known bodies, and these are the guidelines. The goal is to prevent or delay progression to type 2 diabetes. The goal for the management of pre-diabetes is to prevent or delay progression to type 2 diabetes. And the first guideline is to refer individuals with pre-diabetes to an intensive behavioral lifestyle intervention programs modeled after diabetes prevention program. The target is to achieve and maintain 5 to 7% weight loss, engage in over 150 minutes exercise per week of moderate intensity physical activity. The provider of this program is usually registered dietitians or a trained lifestyle coach to ensure efficacy. For the follow-up, we always have up to like 16 sessions in the first 6 months. Why do they need up to 16 sessions in the first 6 months? That's because during the first few months of dietary and lifestyle intervention, patients are likely to drop out if they don't have adequate support. This is a time that they have a lot of questions. How does this food affect my blood sugar? How does this particular food affect my blood sugar? If I do this, what will be the result? If they don't have anybody to ask questions during this critical period, they are likely to drop out of the lifestyle program. And I realized that in Nigeria, most times doctors do not refer patients with pre-diabetes, at the point of diagnosis. They'll likely just give a general advice, like, oh, you have been diagnosed with pre-diabetes, but there's nothing to worry about. Just reduce your carb intake, take enough protein, take a lot of vegetables, exercise. These are general recommendations. But beneath that is a lot of struggle for patients. Patients struggle with, okay, what is the amount of carbs I can take? Should I do away with all type of added sugar, or can I still take in some? So they have so many questions that may not be addressed by the endocrinologist or the GP because of the time constraints. This is why it is very, very important to refer at the point of diagnosis. They'll be able to have all their questions answered. Now, going on to the guidelines for the management of type 2 diabetes, the goal is to achieve and maintain glycemic control, blood pressure, and lipid targets. And for the guidelines, the first guideline is to initiate medical nutrition therapy at the point of diagnosis and integrate it into ongoing care and education. And the second guideline is that MNT should begin concurrently with metformin for most individuals and not sequentially. This means that as you're prescribing metformin, you're also referring this patient to dietitians for proper dietary and lifestyle management. The third guideline is that registered dietitians should provide 3 to 6 encounters within the first 3 to 6 months, and this intensive phase is crucial for behavioral change. As I've explained earlier in previous slide, patients might even need up to more than 3 to 6, they need up to 16 sessions, and this might be like every week consultation until they are able to adapt to the lifestyle modification. For follow-up, after the 3 to 6 months of management, most patients used to see results, tremendous results within 3 to 6 months. After the 3 to 6 months, a minimum of 1 annual follow-up is needed with the registered dietitian, or this might even be more frequent. There might be a need for more frequent quarterly sessions if patients are not meeting their goals. And lastly is individualization. For individualization, the nutritional prescription must be personalized based on patient preferences and comorbidities. This is very, very important. I remember a time when we were trying to partner with a particular hospital to provide dietary counseling to their patients, and the customer representative of that hospital told me that, oh, we don't really partner with diet clinics. That's because we have a general diet plan that we give to diabetic patients, and patients with chronic kidney disease. I was shocked, and at the same time, I was sad because it actually revealed a gap, a huge gap between medical care and nutrition care in Nigeria. The truth is, a particular diet plan or a general diet plan cannot serve everybody with diabetes. That's because everyone is different in terms of their medical history, their nutrients need, their lifestyle, their work schedule. So this diet plan cannot actually meet even comorbidities. So for instance, if a patient is diagnosed with diabetes, it is possible that this patient already have hypertension before. It is like the example that I gave to you. This patient was struggling with hypercholesterolemia, gastric ulcer, and GERD. There is no way a general diet plan of diabetes could meet all the needs of all those comorbidities. So it is very, very important that we know that as health professionals, that we know that individualization is very, very important. A general diet plan cannot serve everybody with diabetes. So patients should be referred to dietitian for proper individualized plan. This is very, very important. Right, so let's go to medical nutrition therapy for type 1 diabetes and gestational diabetes. The goal for type 1 diabetes is carbohydrate estimation for insulin dosing and management of blood glucose. The guideline is that medical nutrition therapy is mandatory. Intensive insulin therapy requires carbohydrate counting skills taught by a registered dietitian at diagnosis and reinforced annually, right? Basically, at the point of diagnosis, endocrinologists or GPs alike should refer to registered dietitians so that patients with type 1 diabetes can be empowered to know how much carbs they need to eat per meal to match their insulin dosage. We're still going to talk more about this, right? For gestational diabetes, the goal is to achieve normal blood sugar levels for women with gestational diabetes. And the guideline is pregnancy is a primary initial treatment. Women with gestational diabetes should receive medical nutrition therapy from a registered dietitian immediately upon diagnosis. And then pharmacotherapy is then added if targets are not met with MNT alone. As with other areas, this aspect is also lagging in Nigeria, where women are first probably placed on medication or probably not referred on time, or probably referred when they're already on insulin therapy. In my own practice, I've received more of patients that are already placed on insulin therapy and probably not seeing results. That is when endocrinologists or GPs will say, oh, I think I have a dietitian that can help you. That is when the blood sugar is probably not responding anymore to pharmacotherapy. So it is very important that women with gestational diabetes are referred at the point of diagnosis and not as an afterthought. Right, so core components of medical nutrition therapy across all types. As registered dietitians, we emphasize on healthy eating patterns. We emphasize on nutrient-dense foods. No single percentage of calories, carbohydrates, protein, or fat exists for all individuals. So we cannot say for diabetes management, compulsorily, maybe 50% must always be from carbs, 20% must always be from protein, and 30% must always be from fat. It differs per individual based on their health goals. I've also seen cases whereby when patients are being referred, the doctors will write, please on 1,800 calories. Most times it's the registered dietitian that we assess the patient and then place the patient on the amount of calories that are needed for management. And the calorie distribution across macronutrients depends on the health goals and the nutrient needs. For carbohydrate management, it's always very important to focus on consistent intake of high quality, high fiber sources of carbohydrates. These are called complex carbohydrates. And in this case, carbohydrate counting can play a role on the place method, as I would later explain. For weight management, let us have in mind that between 5 to 15% weight loss could actually have clinical benefits for patients with all types of diabetes, especially type 2 diabetes. It's very important that how patients lose their weight, to know that how patients lose their weight also matters. If patients go on an overly restrictive diet, it can lead to very high or very low blood sugar, what we call hyperglycemia or hypoglycemia. So patients will just keep fluctuating between hyper and hypoglycemia, which will actually worsen their conditions over time. So is medical nutrition therapy effective in improving outcomes? Absolutely, yes. We have strong evidence that show that MNT is actually MNT provided by registered dietitians help to reduce HbA1c by up to 2% in patients with type 2 diabetes, up to 1.9% in patients with type 1 diabetes within 3 to 6 months. Even more improvements are noticed in patients. So it's very, very important that we also know that medical nutrition therapy can also reduce the risk of complications associated with all types of diabetes. Now let's review our evidence. The first evidence that I have here, the first research that I have here, is an umbrella review of 88 publications with 312 meta-analysis that confirm that beyond weight loss, beyond energy restriction, dietary approach like plant-based Mediterranean diet or high protein diet, along with high omega fatty acid intake, can significantly reduce HbA1c and triglycerides and improve the cardiometabolic health in people with type 2 diabetes. I also leave a screenshot of that on the side of the screen. The next one is a 2021 reward study in the British Journal of Diabetes, which showed that an 8-week very low calorie diet intervention led by healthcare professionals resulted in type 2 diabetes remission. And this highlights the fact that a structured, intensive dietary intervention are feasible and also effective in clinical practice. And this can actually improve the weight of patients and up to the point of diabetes remission. The screenshot is also on the screen. We also have a 2022 randomized control trial that demonstrated that a behavioral intervention promoting between 40 to 60 grams of carbs per day led to a significant reduction in HbA1c and body weight. And this finding suggests that our MAT approach can be a potent tool for both preventing and managing early type 2 diabetes. And lastly, we have a 23 systematic review and meta-analysis in the Journal of Clinical Nutrition, which provides the most compelling evidence that medical nutrition therapy delivered by registered dietitians are effective in patients, in adults with pre-diabetes. This analysis of 13 randomized control trials found that medical nutrition therapy provided by registered dietitians significantly improve HbA1c, fasting blood sugar, weight, body mass index, waist circumference, cholesterol levels, and blood pressure. And this offers the strongest support for the critical role of registered dietitians in diabetes management. Now let's talk about types of eating patterns. Types of eating patterns are beneficial for patients with diabetes. The first one is the USDA Dietary Guidelines for Americans, and this emphasizes the variety of vegetables, fruits, lower fat dairy, variety of protein and healthy fats. And this also this pattern also limits saturated fat and trans fat, added fat, and sodium. The second eating pattern that is beneficial for patients with diabetes is the Mediterranean style pattern. And this emphasizes plant-based foods such as vegetables, beans, nuts, seeds, fruit, whole grains, fish, and other seafoods. Olive oil is the primary source of dietary fat in this particular meal pattern. And we also have low to moderate amount of dairy products and fewer than 4 eggs per week. And the outcomes are clear through research studies. We have reduced risk of diabetes, reduced HbA1c, lower triglycerides, reduced risk of cardiovascular events. The third pattern of eating that are actually very beneficial for patients with diabetes are the vegetarian and vegan diet. And this could mean removing all animal food from animal protein sources from the diet, or including eggs. These are called the ovo-vegetarian, or including dairy. These are called the lacto-ovo-vegetarian. And we have outcomes of reduced, from research studies, we have outcomes of reduced risk of diabetes, reduced HbA1c, weight loss, lowered LDL cholesterol, and improved HDL cholesterol. Now, another model that I've shown to actually the blood sugar control of patients with diabetes is the MyPlate model. There is an evidence that using a plate method like the one described by the American Diabetes Association's diabetes plate model is an evidence-based strategy for blood sugar management in people with diabetes. And if we are to adapt this to Nigerian cuisine, there's a way we can section our plates, so such that half of the plate is to non-starchy vegetable, such as eforivo, ugu, okra soup without excess oil, garden egg, and cabbage. A quarter of the plate goes to lean protein, that is grilled fish, skinless chicken, lean beef, snail, and moi moi. And another quarter of the plate is to quality carbohydrates. By quality carbohydrates, we mean complex carbs, and this can be brown rice or fada rice, small portion of amala, boiled yam, plantain, low-fat dairy, or fruits. And when it comes to MyPlate model, the exact quantity of carbs are not estimated. So it is still very, very important that this is estimated with the help of the registered dietitian. Next is the carbohydrates management. There is a spectrum of patient-centered strategies that can be used for carbohydrates management. The first one is carbohydrates consistency. The goal is to maintain a predictable blood sugar levels, and this is by eating consistent amount of carbs at the same time every day. That means that you're having consistent amount of carbs for breakfast, present amount of carbs for lunch, dinner, and snack time. And this approach is for all diabetic patients, either with or without oral medication. This is just to have a consistent, not that you're having a very high amount of carbs in the morning and then low amount of carbs in the afternoon and probably very high amount of carbs in the evening. You're having this consistent amount, similar portions, right? For basic carbohydrate counting, which is the next strategy, this actually is for patients with flexible insulin therapy. And this helps to estimate the exact amount of carbs per meal. And this could now be, you can talk about this in terms of carb servings. So 1 carb servings is equal to 15 grams of carbs. So you want to know how many carb servings is this patient taking per meal, for breakfast, for lunch, for dinner, how many carb servings per snack. You know, this actually helps to estimate the portions of carbs for patients that are on flexible insulin therapy. The last one here is the advanced carbohydrate counting. This advanced carbohydrate counting is usually estimated using the carb to insulin ratio, and is usually for patients on intensive insulin therapy, like the type 1 diabetic patient or women with gestational diabetes, when they have to take insulin dosage with every meal, right? In this case, dietitians are able to estimate the total amount of carbs that are needed for that insulin dosage per meal. This is called the advanced carbohydrate counting. Now, for other macronutrients, we have the healthy fats and heart health. Dietitians usually emphasize on choosing unsaturated fats, such as extra virgin olive oil, avocados, nuts, and seeds. And it's always better to choose this kind of healthy fats over fats that are very high in saturated fats or trans fats. Palm oil, for instance, there's lots of controversy around palm oil. Some people are saying that it is good for heart health, and people are saying it is not good. That's because it contains a large amount of saturated fat in proportion to unsaturated fat. So it's always good to take palm oil moderately, as research is still inconclusive. And patients are advised to avoid processed foods, pastries, and most of the time, healthy fats account for 5%, depending on the health course or the nutrient needs of patients. For protein helps to promote satiety and also preserve lean muscle. We recommend 0.8 to 1.5 grams per body weight protein of high biological value. And for patients with comorbidities such as chronic kidney disease, the amount of protein recommended depends on the stage of the chronic kidney disease, and this is usually taken from most of the international guidelines for the nutritional management of diabetes. For sugars, sweeteners, and alcohol, for added sugar, patients are advised to avoid added sugar. They can take non-nutritive sweeteners, which have been shown not to spike blood sugar. For alcohol, there are no safe levels of alcohol, so patients are always advised to stay clear of alcohol. Now let's talk about micronutrients and supplements. It is very important to note that the principle here is that supplements complement and do not replace first-line medical nutrition therapy, medication, and lifestyle therapy. They require medical supervision to avoid interaction and toxicity. And the first nutrient here is magnesium. There is a strong evidence that correcting deficiency of magnesium can actually improve insulin sensitivity and improve glycemic control. The primary consideration here is to make sure that patients are getting most of this magnesium from their diet and not necessarily placed on supplements. It's also very important to first test for deficiency before placing patients on magnesium supplements. For vitamin D, there's also a strong evidence for deficiency. Correcting deficiency of vitamin D has also been shown to improve insulin sensitivity. It's always important to test for deficiency before supplementing. Next one is berberine. For berberine, there's potent efficacy that have been shown to be comparable to some oral medications for lowering blood sugar. For constitution, there's a high risk of drug interaction, so prescribing berberine is prescribing berberine must be under strict medical prescription and monitoring. And the next one is omega-3 fatty acids. These actually these actually have modest effects for glucose levels, but stronger for cardiovascular risk reduction. For primary consideration, the evidence for glucose control is mixed, but it is usually recommended for heart health. For the next one is alpha lipoic acid. There are some evidence that this particular nutrient is good for reducing diabetic neuropathy symptoms. The primary clinical use is for nerve pain and not a first-line treatment for glucose control. For nutrients such as chromium, zinc, and probiotics, there are emerging evidence that they may be beneficial for blood sugar control, but evidence is inconclusive, so patients are usually not placed on chromium, zinc, or probiotic supplements. It's better to focus on food sources first. Moving on to herbs and spices. Moving on to herbs and spices. The core principle here is to prioritize food first approach and caution patients against self-prescribing due to risk of interaction with diabetics medication. The first one for herb is tea berberine. Very strong evidence showing that the efficacy is comparable to some pharmaceuticals, but there is a high risk of drug interaction and it requires strict medical supervision. Next one is cinnamon. We have strong evidence that cinnamon helps to reduce fasting glucose levels and reduce HbA1c and insulin resistance. The key consideration here is to make sure that patients are taking Ceylon cinnamon and avoid cassia cinnamon. This is to avoid liver toxicity from coumarin in cassia cinnamon. For fenugreek, there's also a strong evidence that fenugreek can improve fasting and post-meal glucose. And it's always very, very important to note that high soluble fiber content is a key mechanism, so it's very important that the food is high in soluble fiber. The next one is turmeric. There's also a moderately strong evidence that turmeric is potent due to its anti-inflammatory effect. Usually, this requires a high dose of turmeric extract, paired with black pepper for proper absorption. But in the case whereby patients cannot be placed on turmeric supplements, it's best to always tell them to make it themselves at home. The last one is then we have ginger and garlic. There is a moderate evidence for both ginger and garlic, but much more moderate for ginger, showing that ginger can lower fasting blood sugar and HbA1c. Evidence is promising, but require more studies. Garlic, on the other hand, is a modest or limited studies showing that we have to reduce fasting glucose. They are more for improving lipid profile. We have more studies showing that they are more beneficial for improving lipid profile. Okay, so let's talk about interprofessional approach, the dietitian's role on the diabetes care team. The first thing to note here is that diabetes management is not a solitary endeavor. Physicians diagnose and prescribe medications, and dietitians prescribe personalized nutrition. It's very, very important that we bridge the gap between medical care and nutrition care in Nigeria by not carrying out the role of the dietitians. Instead of advising to eat, it's best to just prescribe the medication and refer to dietitians to do this. Close the gap. It's best to know that MNT is the bridge that empowers the patient to implement the lifestyle changes necessary for glycemic control. So basically, medical nutrition therapy places patients on the driver's seat of their life. they are able to know that, okay, this is what I can eat to control. This is the effect of this particular food on my blood sugar. If I eat this particular food, this is the effects. You will literally placing them on the driver's seat of their management. The third here, or the third thing here, is to establish formal referral pathways. For most teaching hospital and government hospitals, there's always there's a better structure for referrals. But in private hospitals, I found that most times there is no proper referral between endocrinologists or GPs to registered dietitians. It's always good to make this referral system very simple. Make consulting a registered dietitian the standard of care for every diabetes diagnosis and annual follow-up. This is very, very important. And the next one here is to embrace shared care plans. It's always good for consultants or endocrinologists to collaborate with registered dietitian on setting unified patient goals for both glycemic targets and lifestyle achievements. There could be a proper communication between registered dietitians and endocrinologists on achieving the health goals of patients. This is very, very important. I've been privileged to work with amazing endocrinologists who refer easily to registered dietitians, refer to us at Cairo Diet Clinic, and make the management of patients easy. So I want to thank those special endocrinologists here. Right, the last one is to embrace our unique expertise. Understand that registered dietitians' role in behavioral change is distinct to achieving metabolic outcome. The best, so most of the time, the best gift you could ever give to your patient is referring them to registered dietitians so that they can quickly solve the diet puzzle. Once they're able to fix that puzzle, once they're able to fix that particular gap, you find out that every other thing comes to place. Right. So let's talk about us at Cairo Diet Clinic. As Cairo Diet Clinic, Cairo Diet Clinic is an outpatient clinic that provides evidence-based nutrition information and offers consultancy in every aspect of nutrition, meaning from childcare to family nutrition to weight management and nutritional care of health conditions. Our experts are registered dietitians specializing in various aspects of health and qualified to answer various nutritional questions that patients might have. We also have a client's testimonial here. We have so many testimonials on Google. You can check us out and type Cairo Diet Clinic on Google. You will see many reviews there. Because of our time, our conclusion, medical nutrition therapy is an evidence-based, effective first-line therapy in diabetes management. Personalized, culturally sensitive approach are key to patient adherence. Also, simple tools like plate method can be powerful and effective. Managing diabetes in Nigeria requires leveraging local food and addressing local challenges. A team-based care model that includes registered dietitians yields the best patient outcomes. And lastly, empowering patients with nutritional knowledge is empowering them to take control of their health. Emphasis on that again. Empowering patients with nutritional knowledge is empowering them to take control of their health. Thank you very much. And here are a few references. And we're going to have the questions and answers. Thank you very much.
So thank you, Mrs. Olajumoke, for that very lucid and a well-delivered lecture. Before we commence on questions, comments, and let me quickly just give a preview of what she has said. So she talked about the medical nutritional therapy involving management of obesity, hypertension, DM, pre-diabetes, and even chronic kidney disease. She spoke on the rising prevalence of DM globally and even in Nigeria and Africa. And she defined what medical nutritional therapy is, which is an evidence-based therapeutic diet, to manage different medical conditions. And she now honed down on diabetes, talking about the different guideline recommendation in terms of diet for pre-diabetes, talking about the guideline and the reason why you must quickly institute medical nutritional therapy is to prevent or delay progression to overt type 2 DM. She talked on exercise also being very complementary to medical nutritional therapy. She also went further in talking about for pre-diabetes that they might have more than 16 sections in the first 6 months, which is very important for achieving the success of reversal of pre-diabetes. She went further to talk about the types of eating pattern. You know, she looked at Mediterranean style, vegetarian style, the USD dietary guideline. And she also talked about the plate model, talking about the shared different nutrients, carbohydrate, protein, and vegetable within a serving plate method. She talked about type 1 DM in terms of carbohydrate counting, GDM, which medical nutritional therapy forms the first line of management in GDM. And she also talked about type 2 DM in terms of lipid management, and also for prevention, lipid management, glycemic control, and to manage other comorbidities like obesity and also hypertension. She mentioned various examples based on evidence-based guidelines and studies that have shown some of the foods and their benefits in different health conditions. So at this point, we want to really appreciate Mrs. Olajimoke for taking out time to take this presentation despite a very tight schedule. So at this point, questions are entertained. So if you have any question, you can raise your electronic hand. I think I'm seeing Dr. Gabriel Oluwole. Is it the one raising the hand? Okay. Okay, sorry, it's not the one. So we can raise our electronic hand, or we can drop our comments in the comment section. So I think there's already a comment already. Dr. Diaolu talking about thank you for revolutionization of medical care. Then talking about Dr. Isiawe, she said, thank you for a very illuminating talk. This very important point cannot be overemphasized. She talked about the medical nutritional therapy should not be treated as a spare tire or a panic button in diabetes and endocrine care, but should be a core part of care, re-emphasizing the importance of multidisciplinary team approach to ensure better outcome of patients. So this from Dr. Isiawe. Another point from Dr. Asupon Eso says, thank you, Ma, for the very nice presentation. Please, any Nigerian national guideline for nutritional management in DM, does Nova Diet have any role in your practice? So I think the question here is, the first question here is from Dr. Asupon Eso, talking about the role of Nova Diet. So when we are still awaiting more questions, comments, I think Mrs. Olajimoke Osunsoya, you can please address this question on the Nova Diet. Thank you very much.
Thank you, sirs and ma'ams, for the
Please kindly mute your mic, please, so that we don't have distortion. Yes, okay. So you can go ahead, ma.
Thank you, sirs and ma'ams, for this very powerful opportunity. I really appreciate the opportunity given to present. I think somebody is still talking.
Please, can you mute your mic, Dr. Omoba? Dr. Omoba, please, can you mute your mic?
Okay, I think, okay, all right. Thank you very much, ma'am. So thank you everyone for the opportunity. There are no studies on Nova diets. As you can see, I was able to outline the dietary patterns that we have enough studies on. The dietary patterns that we have enough studies on include the USDA Mediterranean diet. Some also use the DASH diet, but we don't have enough evidence that DASH diet helps with blood sugar management. You know, some people go for vegan diets. We have enough studies on those ones, but we don't have enough studies on Nova diets. The diabetes, my plate diabetes model is also a very good one. If you notice, the ones that I outlined are the ones that we have enough studies on. We registered dietitians only work with evidence-based strategies.
for our patients. So we don't have enough evidence on over diets. Thank you.
Okay, thank you, Ma, for that very well answered question. I don't know whether there's any other questions or comments as we move ahead. And soon we are going on a tea break. So I'm trying to see whether there's any comments on the chat box. Any other comments? So I think those are the comments made so far. We really want to appreciate your time for coming around to give this pre-conference update lecture. We really don't take it for granted. Thank you so much. Yes.
You're welcome, ma'am. Thank you very much.
Yeah. So to move further, we'll be going on a tea break, but I just want to let you know what awaits the second section of this presentation. In this second section, we'll be talking about the current guideline in the management of polycystic ovarian syndrome. From there, we'll be moving to newer agents in the management of type 2 DM. We'll talk about evaluation and management of short stature in the next set of presentation. We'll also be looking at endocrine disruptors. They are really with us, and we need to identify them. Then we'll be talking about animal rights. So you can't just pick any rat or any chicken and kill anyhow so that you don't get yourself arrested. So we'll be looking at all this together in the next section, and we'll just have a 30 minutes break. Please keep to time. There is no African time in this presentation because we're in quest for time. And so we'll take a 30 minutes break now. They're starting now. And the time now is 11:55. And by 12:30, we'll be resuming back on this section. So please have a nice time and come with your jotters, your biros for the next section. Thank you very much for your patience and time. Okay, so bye for now until 30 minutes time.
So, good afternoon, everyone. Am I audible, please?
Yes, you are audible, sir.
Okay, great. So, good afternoon and welcome back from the break, everybody. So, we'll be taking the next presentation, and Dr. Okno will be our resource person for the next presentation on polycystic ovarian syndrome. It is a great delight for me to be the one to give us citation. So permit me to read Dr. Bolanle Okunowa's citation. Well, it's an abridged profile. So I'm very sure that our profile is much more than this. But suffice to say for now, we'll just give an abridged version of our profile. Dr. Bolanle Okunowa is a fellow of the Medical College of Physicians. That's national. Also a fellow of the West African College of Physicians. And she's a member of the Endocrine and Metabolism Society of Nigeria, EMSON. And indeed, she's our current treasurer of the Association of Clinical Endocrinologists of Nigeria, ASEN. Dr. Okunowa has won several awards, including the International Society of Endocrinologists Award, in recognition of her passion in research. She is a certified diabetologist of Leicester University, United Kingdom. She currently works as consultant diabetologist and endocrinologist at the prestigious Lagos State University Teaching Hospital, Ikeja, Lagos, here in Nigeria. It's my delight and my great pleasure to welcome Dr. Bolanle Okunowa to take her presentation on management of polycystic ovarian syndrome in Nigeria. Please, let's give her a warm welcome. Thank you very much, ma'am, for joining us.
Okay, thank you so much, sir. I really want to appreciate the Endocrine and Metabolic Society of Nigeria for this privilege to be able to take this lecture. So I'll be talking about the current guideline in management of polycystic ovarian syndrome. So these are my outline. Introduction, we'll be looking at introduction to polycystic ovarian syndrome. We'll be looking at epidemiology, pathophysiology, clinical features, look at treatment criteria, medications, and we'll prognosticate. As a way of introduction, polycystic ovarian syndrome, which I'll be using interchangeably as PCOS, has been known since 1935, when Steen and Leventhal described a syndrome consisting of bilateral polycystic ovaries, thickened ovarian cortex, amenorrhea, hirsutism, and infertility. It is said to affect 60 to 20% of women in the reproductive age group. And PCOS usually manifests in the second to third decade of life, just after menarche for some of the women. So as a way of definition, let's look at what the definition of polycystic ovarian syndrome is. It's a set of symptoms related to hormonal imbalance that affects women and girls of the reproductive age group and is diagnosed by a combination of signs and symptoms of androgen excess, ovarian dysfunction, and ultrasound features of polycystic ovarian morphology. So in terms of epidemiology, it's a familiar condition. In fact, studies have shown that it's the means of inheritance is usually autosomal dominant in most families. So 50% of first-degree female relatives are at risk of having this PCOS. Various genes have been identified to be linked to the onset of PCOS. That's cytochrome 17A, cytochrome 11A. Even the insulin gene regulatory region near chromosome 19 has been identified. Also, there's increased central adiposity in patients with PCOS. And so these have been linked to PCOS, insulin-resistant diabetes. And studies have shown that women in East Asia with PCOS has lower BMI compared to African who have higher BMI with a lot of metabolic complications. Also looking at the ethnicity, ethnicity plays a role in the phenotypic manifestation of a woman with PCOS. So a relative mild phenotypic presentation is seen in Caucasians with normal BMI, but Caucasians with higher BMI, like those seen in North Americans and Australia, have a more severe phenotypic presentation. Also, severe hirsutism has been shown to be more prevalent in those from Middle Eastern, Hispanic, and Mediterranean women. And also, the East Asia and women have less hirsutism compared to the Caucasians with the same serum level of androgen values. So, in hirsutic women, they are at increased risk of acne, menstrual irregularities, and acatosis nigricans, which is a sign of insulin resistance. So like I said earlier, autosomal dominant is a mode of inheritance for most families according to studies. And studies have shown that fathers of women with PCOS can be abnormally hairy, and female siblings may have hirsutism and oligomenorrhea, and mothers may also have oligomenorrhea. So still on the pathophysiology, the etiology is not clearly defined, being that it's multifactorial and polygenic in nature. The current perspective view of PCOS viewed it as a complex disorder with numerous genetic variants and environmental factors that interact to cause the onset of this pathology. So still on the pathophysiology of PCOS, there's increased luteinizing hormone and increased insulin stimulation in patients living with PCOS. So what does these two do? They cause a drive of ovarian androgen production. So the increased LH and increased insulin stimulation all combined to inhibit hepatic sex hormone binding globulin and makes free androgen available in the systemic circulation, causing hyperandrogenemia. The hyperandrogenism now leads to hirsutism, menstrual disturbances, and infertility. Like I said earlier, that most women with PCOS, especially in Africa, they are usually obese, and this obesity is associated with insulin resistance. Those there is hyperinsulinemia, so it's like a chain reaction. So looking at the androgen excess in polycystic ovarian syndrome makes those women prone to hirsutism, like I said, acne, androgenic alopecia, irregular menstruation, cardiovascular risk. They are prone to a lot of cardiovascular risk, hypertension, hypertensive heart disease, chronic kidney disease, dyslipidemia, and even type 2 diabetes mellitus. So looking at the clinical manifestation of this patient, they can present with anxiety, they can come depressed, they can have low self-esteem of themselves, they have poor body image distress because of the obesity, and all this contribute to reduced quality of life in those women. Dermatologically, they can present with acne, androgenic alopecia, hirsutism. They can have, like we said, reproductive infertility, oligomenorrhea, and cardiometabolic presentation can be obesity, insulin resistance, hyperglycemia or dysglycemia. They can present with prediabetes, hyperinsulinemia, dyslipidemia, and even hepatic steatosis. There are various diagnostic criteria for PCOS. We have about 4 diagnostic criteria for PCOS. So we'll be looking at the 1990 National Institute of Child Health and Human Disease of the United States National Institute of Health, which proposed 2 out of the following 3 criteria. The first one is presence of oligo-ovulation or anovulation, which is manifested as oligomenorrhea or amenorrhea. Also, they can present with androgenism or hyperandrogenemia. Androgenism just means the clinical evidence of androgen excess, but hyperandrogenemia means you have a biochemical evidence of androgen excess. And the important third one is exclusion of other disorders that can result to menstrual irregularities and hyperandrogenism. This third part of the criteria is very mandatory because there are many medical conditions that can mimic polycystic ovarian syndrome. So you must be able to exclude other disorders before you can hone down on the fact that the patient has a polycystic ovarian syndrome. So this criteria requires 2 out of 3. So in 2003, the European Society of Human Reproduction and Embryology and the American Society of Reproductive Medicine they used the Rotterdam criteria, which also recommends at least 2 of the following 3 criteria. Oligo-ovulation or anovulation manifested as oligomenorrhea or amenorrhea, hyperandrogenism or hyperandrogenemia, or presence of ultrasonography findings of polycystic ovary. So another diagnostic criteria is the Androgen Excess and Polycystic Ovarian Syndrome Society, which published their criteria in 2009, emphasizing the society opinion on the diagnosis of polycystic ovarian syndrome. So they too says a clinical or biochemical evidence of hyperandrogenism, evidence of ovarian dysfunction, either as oligo-ovulation and or polycystic ovary, and exclusion of related disorders is quite mandatory. So looking at another diagnostic criteria, that's the Society of Obstetricians and Gynecologists of Canada, they indicated that a diagnosis of polycystic ovarian syndrome is made in the presence of at least 2 of the following 3 criteria when congenital adrenal hyperplasia, androgen secreting tumors, or Cushing's syndrome has been excluded. So you can't make a diagnosis of PCOS without excluding this crucial cause of menstrual irregularities or hyperandrogenism. So, and their criteria still says oligo-ovulation and ovulation, clinical and biochemical evidence of hyperandrogenism, and polycystic ovaries on ultrasonography, which is evidenced by 12 small antral follicles in 1 ovary. So this is just a summary slide of polycystic ovarian syndrome, talking about the National Institute of Health criteria, the androgenic, we have 1990 and 2012 for National Institute of Health criteria. We have androgenic excess PCOS Society criteria, Rotterdam criteria. So based on this criteria, a patient with PCOS can present with 4 phenotypes. So they can present to you with 4 phenotypes, and you must be able to identify which phenotypic classification the patient belongs to. So we have phenotype A, B, C, and D. For phenotype A, they present with hyperandrogenism, ovulation dysfunction, and polycystic ovary morphology on ultrasonography. For type B, they present with hyperandrogenism and ovulation dysfunction. For type C, they have hyperandrogenism and polycystic ovary morphology on ultrasonography. For type D, which is the non-hyperandrogenic polycystic ovarian syndrome, they just have ovulation dysfunction and polycystic ovary morphology on ultrasonography. So when you assay type D testosterone or androgen level, it's usually within normal. So that is phenotype D. So this is just still a summary of the criteria as listed, and all the criteria you can see is talked about exclusion of conditions that mimic PCOS before you can hone down on PCOS. That's why it's so important that a good history examination is done so that you can be able to know whether this patient is truly a PCOS or they have other conditions causing the excess androgen or menstrual irregularities. So let's look at the diagnosis of adolescents with PCOS. According to the statement by Rotterdam criteria, it says all the 3 criteria must be present before diagnosing PCOS in adolescent group. And the recommendation, which is a level, the level of recommendation is B, talks about individuals with PCOS manifesting in the adolescents with obesity, hirsutism, irregular menstruation should be treated. And they should not just be left because they are just adolescent. That no, when you get to when you are ready to get married or something, that will treat you. You should treat them. So now let's look at the differential diagnosis, because we've been talking about differential diagnosis is important to be ruled out before you can cone down on polycystic ovarian syndrome. So looking at virilizing ovarian or adrenal tumor, this usually presents as a rapid and progressive onset, and they have severe hirsutism, clitoromegaly, and increased muscle mass. They can even have change in their voice. And when you assay the total testosterone, usually greater than 200 nanogram per DL. And when you do a radiological investigation with CT scan of the pelvis, you can pick the ovarian tumor or you can pick the adrenal tumor. So the other differential that is close to PCOS is the non-classical congenital adrenal hyperplasia. They present with, they are due to 21-hydroxylase deficiency, and this can be diagnosed using the 17-hydroxyprogesterone, which helps you to differentiate between polycystic ovarian syndrome and non-classical adrenal hyperplasia. And this non-classical adrenal hyperplasia usually present in children. They have premature puberty, they have acne, accelerated growth, and even advanced age. Other differentials are Cushing's syndrome, which can cause menstrual irregularity, obesity, acne, idiopathic hirsutism. There are some people that are just airy. You can't really find a cause to it. And it's not even familiar. It just occurs. And other findings on screening them are all negative. Also, hyperprolactinemia can cause menstrual irregularities, and hyperprolactinemia can come from pituitary adenoma, microadenoma. So you must be able to rule out the cause of this hyperprolactinemia before you can now, cone down on polycystic ovarian syndrome. Also, drugs have been implicated. Hypothyroidism is one of the causes of menstrual irregularities. And so for a patient you are screening for PCOS, you must be sure that this is not an hypothyroid patient. That's why a very good history will guide you. If a patient is complaining of cold intolerance, weight gain, generalized body weakness, and the rest, you might be thinking towards hypothyroidism. So there can also be familial hirsutism. There are some people in their family, they are hairy. Their hairy is being there. That's the way they are, and they are not polycystic ovarian syndrome. So all these things must be carefully ruled out before you can cone down on polycystic ovarian syndrome. So now it's important we assess these patients, and both laboratory radiologically and a clinical assessment. There are different clinical assessment scores we can use for patients living with polycystic ovarian syndrome. We have the modified Ferryman-Garway score, and this is used to assess the level of hirsutism, whether it's mild to severe. Also, for androgenic alopecia, the Ludwig visual score is preferred to assess the degree and distribution of alopecia. Okay, I hope I'm still audible. Okay, so also for acne, they need to be assessed. So there's some calculation you can do, like for the free testosterone, free androgen index, and there are some people that their testosterone levels are within normal. You can assay for dihydroepiandrosterone levels, sulfate. So other laboratory findings can be, you need to do serum prolactin. You must rule out hyperprolactinemia from oral glucose tolerance tests in obese patients and people with type 2, to rule out type 2 DM, because patients with PCOS are prone to type 2 DM. Also, you must rule out hypogonadotropic hypogonadism, which presents with low estradiol and low follicle stimulating hormone. Also, you must rule out premature ovarian failure, and this presents with low estradiol and elevated follicle stimulating hormone, unlike in patients with PCOS that have elevated luteinizing hormone. Also, you do the sex hormone binding globulin. Like I said, that in the pathophysiology, there's inhibition of production of sex hormone binding globulin from the liver. So you can see it as either normal. Star function tests can be done to rule out hypothyroidism. So in terms of investigation radiologically, transvaginal scan is preferred if the patient is sexually active. But if the patient is not sexually active or the age is less than 8 years, it is not preferred. It's actually not allowed. So this is the ultrasonography findings of polycystic ovaries. You can see the multiple cystic ovaries, antral follicles within the ovary. So this follicle should be 12 or more, 2 to 9 millimeter per ovary, and the ovarian volume should be greater than 10 cm cubed. According to the International Evidence-Based Guideline for Assessment and Management of Polycystic Ovarian Syndrome 2018, using endovaginal ultrasound transducers says that a follicle number per ovary must be greater than 20. And the volume still greater than or equals to 10, ensuring no corporal luteal, cyst, or dominant follicles are present to make a diagnosis of radiological finding of polycystic ovarian syndrome. So now, what is the goals of management of PCOS? You really want to treat the symptoms. You want to manage the obesity and the psychological impact of the disease. You want to restore ovarian cyclicity. You want to treat anovulation infertility. You want to restore their menstrual regularity. So the current guideline for management polycystic ovarian syndrome, emphasizing a holistic, individualized approach, is individualized. So it's not one cap fits all. So depending on many factors of that patient, you individualize the treatment of this patient, focusing on lifestyle modification, symptom management, addressing potential long-term health risks. So the treatment plans are tailored to each patient's specific need. So for a person with a younger age woman, is different from that of an older woman. A woman desirous of pregnancy is different from that not yet desirous of pregnancy. And also presence of other health conditions, like I said earlier, that they are prone to a lot of cardiovascular complications and even cerebrovascular complications. So those with complications already, the treatment is totally different from those without complications. So lifestyle modification is very paramount according to the current guideline of management of polycystic ovarian syndrome. There's a strong association between obesity, hyperandrogenism, impaired glucose tolerance, menstrual abnormalities, and infertility. So lifestyle issues should be properly addressed in women with polycystic ovarian syndrome. And this requires careful education, health education, counseling, regular follow-up, and weight optimization is very paramount. Like 50% of women with PCOS are on the obese side. So you talk about exercise and adequate nutrition. For these women, a dietitian, a nutritionist will be very essential in the management of these patients. Also, studies have shown that with 5 to 10% reduction of weight, you can cause significant improvement in reproductive function and metabolic function. So studies have shown that with 5 to 10% reduction of weight, ovulation dysfunction can be reversed, and some of these women can actually achieve spontaneous pregnancy. And the loss of abdominal fat may be the best predictor of weight loss. So looking at anovulatory infertility, beyond the artificial reproductive technology, there are other mechanisms to which you can use to induce ovulation in these women. So like using clomiphene citrate, you can use it to induce ovulation. Aromatase inhibitors like letrozole, these are the dosing of these drugs. You can use it to induce ovulation. Gonadotropics are not really used, they use more of, but it can be used also. Also, patients with metformin, studies have shown that patients using metformin, because metformin helps weight loss and it also improves glycemic control, some have been said to have ovulation induction, as in ovulation dysfunction corrected. So now, like I said, the management is individualized, and you have to prioritize this on the need of the patient. If a patient fertility, you want to prioritize this If the person has no infertility issue, no fertility, no fertility wishes, that means the patient is not ready to have a child, to ensure that the patient have endometrial shedding for at least 3 months. So there are the drugs you can use, like estrogen, progesterone, contraceptives. You can use that to cause regular shedding of endometrial lining or progesterone, 10 milligrams daily for 7 days. And this is because of the risk of endometrial hyperplasia progressing to endometrial cancer in this way. So for the treatments of hirsutism, depending on the severity, if it's a mild hirsutism, hirsutism constitutes cosmetic issues for women. So if it's mild and focal hirsutism, so there can be shaving, plugging, waxing, or sometimes they can even require laser treatment. The hirsutism is so severe to require a trichologist in the management of this patient. Also, there is hair removal cream like eflornithine, which can be rubbed to the affected side. And this sorry for a break in transmission. So for severe hirsutism, you can use some medication, like I said, finasteride, flutamide, spironolactone. Spironolactone. Okay, so in terms of cardiovascular disease, PCOS is associated with increased risk of cardiovascular disease, dyslipidemia, hypertension, hypertensive heart disease, chronic kidney disease, and even type 2 diabetes, pre-diabetes. So this is a summary of the treatments I've talked about. For infertility, obesity, they can be prone to sleep apnea, so they must lose weight. They might even need a CPAP or the review of a pulmonologist. So you really want to prevent endometrial cancer, manage diabetes, or if they have gestational diabetes, treating fertility, and other cardiovascular complications. So for skilled medical treatment of ovulation restoration, there are various laparoscopic that have been employed, and this is electric laser drilling and multiple biopsies. And studies have shown that 40% of the men can achieve ovulation and spontaneous pregnancy after these procedures. So what's the prognosis? So the prognosis, because this women risks of cardiovascular and cerebrovascular diseases, so you must manage this disease. So you screen and manage quickly. Sorry, I think the network is a bit okay. So like they are prone to obstructive sleep apnea. So if they have it, you want to treat, and they might require CPAP or review by pulmonologist. They can be at increased risk of endometrial hyperplasia or carcinoma, so they must be screened. And studies have shown that there is no association with breast cancer, ovarian cancer, and there's no additional surveillance for patients with PCOS. So in conclusion, PCOS is one of the most common endocrine disorder that affects women of reproductive age. Etiology is heterogeneous, can be multifactorial, polygenetic, and is associated with cardiovascular and cerebrovascular complication. Prompt diagnosis and proper management is crucial, and it is important for us to know that with good and proper management, some of these men might not need artificial reproductive technology like IVF or insemination, and they can actually achieve spontaneous pregnancy. And lifestyle management is one of the core, the guideline is emphasizing now in terms of management of polycystic ovarian syndrome. So these are my references. And September is PCOS awareness month. And so this opportunity gives me the chance to take this awareness of parents. So very much. At this point, I want to question before we call on the next presenter. Thank you very much.
Thank you very much.
Hello, sorry, I think the network. So I think I've seen a comment. Let me just respond to the comment. For the slides, we are working on it, on sending it to the participants, and we are working on it. Okay.
So if I can say, hello, am I audible now? Hello?
Hello, sir. Yes, we can hear you now. Yes, sir.
Okay. So sorry, the network is a bit shaky. So I was saying that thank you very much for the wonderful presentation. I think it was brilliantly delivered. So just to summarize some of the highlights of the presentation, you talked to us about what polycystic ovarian syndrome actually means as a metabolic problem. And you went ahead to also discuss the pathophysiology, highlighting the role of insulin resistance, how it affects the follicle stimulating hormones and also the luteinizing hormone. You also talked to us about the presentation, the various genotypic and phenotypic presentation that they may have, and also looked at the clinical presentation from the neurological aspects. Interestingly, that they can come down with depression, anxiety, and the androgenic pictures of the androgenic features that citizen, the oligomenorrhea, and present with pre-diabetes, hypertension as a possible presentation. She also discussed diagnostic criteria and explained the role of hyperandrogenemia and also hyperandrogenism, trying to make a distinction between the two. She also looked at the menstrual irregularity that they may present with oligomenorrhea and also amenorrhea. Then she also talked about the phenotypic appearance B, type C, and type D, demonstrating to us that patients with polycystic ovarian syndrome could have various phenotypic presentation. She went ahead to discuss the various differentials from adrenal tumors to the non-classic CAH, and also I would want to exclude before making the diagnosis. Then she also mentioned the clinical investigations that we are likely to do. That's where your fasting blood glucose will come in, and also to make a diagnosis, your LH, FSH, the sex hormone binding globulin, serum testosterone. Those are important clinical investigations to consider. And also your prolactinemia, you want to be sure. Sometimes they can also present with hyperprolactinemia. Okay, so, and she talked to us about the treatment, the goals of the treatment, how it should be individualized based on the age of the patient, if the patient is desirous of pregnancy, what we should use, the role of metformin when in patients like this. He also talked to us about the use of progestins, the oral contraceptive pills, how they've been very useful in relieving some of the symptoms vis-a-vis the menstrual irregularity. And then also to manage individual symptoms like hirsutism. He also made mention of some of the things that medical therapy-wise that we can use. She concluded by stating that it is something that we need to consider in our practice, the diagnosis. She mentioned some of the criteria that we can use to make a diagnosis of polycystic ovarian syndrome. And it is worthy of note that it's a disease entity that the gynecologists are also trying to wrestle from us. So I think it is high time we step up to the plate and begin to manage patients appropriately, particularly patients with polycystic ovarian syndrome. So again, it's just a wrap up. Thank you very much for the presentation, Mark. We welcome questions from the okay. So someone is asking if we can get the slides. I'm sure it will be sent to us. Someone is also asking is asking, thank you, Ma, for the very nice presentation. Please, any Nigerian national guideline for nutritional management a bit different. So I think it's just okay. Ma. Hello? Hello?
Okay, sir. So I can hear you. There was a little breaking now. I can, yes, sir.
Okay, someone was asking what are the androgenic features in PCOS?
That's okay. Okay. The androgenic features of it, I can see that on the chat box. So the androgenic features present acne, androgenic alopecia. They can present with menstrual. And also because studies have shown that women with polycystic ovarian syndrome are at par in terms of cardiometabolic risk, like a man, because of the effect of androgens on them. So they are at par in terms of increased cardiovascular risk and cerebrovascular risk in this patient. So they can present with menstrual irregularities, they can present with androgenic alopecia, they can present with androgenic, not gynecological obesity, truncal obesity in them. So these are all the androgenic features. So it makes them prone to cardiovascular complications, hypertension, dyslipidemia, and the likes from the effect of the excess androgen in a woman with PCOS. So thank you very much. I don't know whether there is any other questions.
Okay, so from here, there are no questions on the chat. Okay, somebody said, thank you, Ma, for the well-elaborate presentation. I need more clarity on role of gonadotropins in PCOS.
Okay, caution, but the guidelines recommend the more of the clomiphene citrate and the aromatase inhibitors, and it's not saying so much on the use of gonadotropin. So, but in some cases it can be used, but with a lot of caution, because it's quite very, very expensive compared to the other drugs, and also its role in disrupting the ovarian uterine axis and the pituitary ovarian uterine axis. So because of that, the guideline is not really saying much on it. So I think that's the way I will put in that question. Answers. Thank you. I don't know whether there's any question. I hope I answered all questions. Okay.
Yes. Thank you. Thank you once again for the wonderful presentation. Thank you.
The opportunity. Presenter in this course of array of topics, and so sorry for the break in transmission. I think at our end it's raining. So, Nigeria rain and internet, but so the next presenter is Professor Olufemi Fasomade, and is going to be talking on endocrine disruptors, because they are here with us and we really need to be aware of their dangers. So I'll quickly give a citation of Professor Olufemi Fasomade. He's a professor of Department of Medicine, College of Medicine, University of Lagos, Nigeria. Is a consultant endocrinology and professor of medicine, Unilag, director of student affairs, CMU. Professor Olufemi Fasomade received his MBBS from the University of Ibadan in 1987. He had his residency training in Lagos University Teaching Hospital, Lodz, Nigeria, between 1989 and 1994. Maybe I was in primary school then. He is a research assistant. He was a research assistant in the same unit 1994 to 1998, and a short training fellowship in City Hospital, Munich in 1994. He was appointed consultant endocrinologist in 1997 by the General Hospital, Lagos Island, Nigeria, where he was from 1997 till 2012. Medicine, University of Lagos, CMU in 2002, and he has remained there, where he steadily rose to the post of full professorship in February 2019. He has been involved in several research areas and have had several grants, including that of the world-renowned AADM study group, which has brought so much knowledge in the areas of diabetes, susceptible genes in African and African Americans. The Care Nigerian project, which characterized the poor level of diabetes control across several tertiary centers of health in Nigeria, and the IDMPS program, among others. Professor Fasomade has many caps on him. He's the unit head of endocrinology, diabetes, metabolism division of Department of Medicine in the CMU Health and Lagos University Teaching Hospital. He was once the chairman, Medical Advisory Committee of LUTH. His tenure ended in 2019. Thereafter, he was appointed the Chief Clinical Coordinator in the NSIN LUTH Cancer Center in September 2022, a position he held till September 2023. He is the former president of Endocrine and Metabolism Society of Nigeria and the past chairman of the Nigerian chapter of American Association of Clinical Endocrinologists. He is an examiner and the immediate past subspecialty head, endocrinology, diabetes, metabolism of West African College of Physicians. Is currently the dean of the Faculty of Clinical Sciences in the University of Lagos and also a director of Student Affairs, College of Medicine, University of Lagos. He has authored and co-authored 5 books. He has more than 120 publications in peer-reviewed journals and more than 300 abstracts and posters presented locally and internationally. He has trained and supervised more than 30 fellows, that means specialists in medicine, which are one of them, surgery, family medicine, cardiology, and other specialties, several of whom are now in the aim of affairs in many hospitals, universities within and outside the country. He has held several managerial positions within and outside the academic and medical community. Please join me as we welcome our distinguished professor, Professor Olufemi Fasomade, to take his presentation. Thank you, sir.
Good day, ladies and gentlemen. My name is Professor Olufemi Fasomade. I'll be talking about endocrine disruptors today. I work in the Lagos University Teaching Hospital and also in the University of Lagos. This will form our outline. We want to look at what is an endocrine disruptor, where do they come from, how do diseases take cause, manifest, and how can we prevent endocrine disruption. We'll follow these 4 broad subdivisions of the lecture, and we hope that you will gain something from it. So what are endocrine disrupting compounds? I will abbreviate them subsequently as EDCs. They are chemicals that interfere with the body's hormones and the endocrine system. Very often you find that they can mimic or they can block or alter natural hormones that regulate growth, development, reproduction, and metabolism. And so you find out that they lead to hormonal imbalance. They usually are found in household items or industrial items such as plastics, pesticides, cosmetics, and even in food and water, and can pose risk to human health and life. So they are virtually ubiquitous. If you go to work, you are exposed to them. At home, you're exposed to them. Whether you're in the rural area or you are in the urban areas, you can be exposed to EDCs. It is a chemical that interferes with the normal functioning of the endocrine system and the reproductive and other biologic processes that are regulated by these systems. A typical endocrine disruptor can mimic a hormone. So they may have some groups in their own structure that are similar to the groups of particular hormones or their targets. And for this reason, it means that they can either block hormone receptors or they can stimulate them. So they can cause diseases where it appears there is a hormone excess, or diseases that can appear like hormone deficiencies. You find them, as I said earlier, almost everywhere. And currently there are thousands and thousands of EDCs that have been discovered and named, and they come on various categories. One of the ones that has been most investigated is bisphenol A. It's one of the most investigated. Also, DDT, that is used to be a popular pesticide, and other pesticides are examples of how you can come in contact with endocrine disrupting substances. So a lot of research and policies regarding endocrine disrupting substances are based on study of these chemicals, which you can say are like prototypes. Typically, bisphenol A, for instance, it acts on the cell, and you can see the schema here that shows how it acts, how it crosses the cell membrane, and then goes into the nucleus of the cell through the cytoplasm, and then it will alter gene expression. And a typical effect of this is that it alters the expression of several of the genes that are responsible for normal testosterone secretion. So eventually, people that are exposed to sufficient amounts of bisphenol A will have a reducing level of testosterone. It also inhibits estrogen binding to receptors, and BPA can also bind to glucocorticoid receptors. It can increase circulating LH and FSH. Therefore, it can affect reproductive cycles. Also, it has effects on the pituitary gland and effects on the sex hormones. So you can see that BPA therefore has a wide effect that borders on disorders of reproductive cycle, borders on the sex organs, and also dysregulates the thyroid hormone secretion. So where do we get most of these endocrine disrupting substances? Well, you can get them from various household items, paints, fire retardants, organic solvents, from our food, from our drugs, even from livestock. If, for instance, you are eating fish, you could be eating a lot of endocrine disruptors, especially if some pollutants have been poured into the sea. So what do these disruptors do? A typical thing that they do is that they can affect reproductive health because of the effect on the hormone levels and the effect on the ovaries and testes directly. They can lead to metabolic disorders, commonly obesity, diabetes, dyslipidemia, and phenylketonuria. They can also lead to hormonal disturbances in the area of thyroid, adrenal, and others. So you see that all of these disruptors have wide-ranging effects. And you can see the sources of these disruptors. They come from cosmetics, pesticides, synthetic hormones, chemical dusts, ultrafine particles, nanomaterials, and the like. We can see this schema also too talking about the sources of these endocrine disruptors. Some of them are environmental, and they have diverse effects on different aspects of metabolism and endocrinology. So you can see that endocrine disruptors, they are widespread, and their effects on the endocrine system are also widespread. They also lead to some cancers. So typically, the conditions that these endocrine disruptors cause include obesity. Obesity is quite common when you have endocrine disruptors in circulation. So quite a number of people that you may see that are obese, it's not all the time that it is genetic or it is due to the food, but could be due to endocrine disruption because the EDCs affect the adrenocortical axis, the ACTH adrenal axis. Also, these endocrine disruptors can lead to diabetes. And usually this could also be due to diverse effects either directly on the islet cells or effects on insulin resistance or effects on insulin secretion. A lot of endocrine disruptors have been linked to cancers, especially endocrine-related cancers. For instance, ovarian cancer, vaginal cancer, testicular cancer, prostate cancer. A lot of these cancers are all related to the prevailing amount of endocrine disruptors in the circulation. A lot of infertility and subfertility is prevalent in the world today, and current estimates suggest that about a quarter of all married people will have infertility or subfertility. And a lot of this is mediated by these endocrine disrupting compounds. Because as we saw in some of the previous slides, the EDCs affect the secretion of LH and FSH. They also alter the balance between estrogen and testosterone so that they can reduce sperm count, they can reduce libido, they can alter reproductive cycles, and they can have diverse effects on the people that they have been exposed to. And this is part of the reason why when you look at global fertility estimates, you find that with each passing year, the number of infertile people continue to increase. And researchers have found long over time that sperm count has steadily declined in mankind over the decades. Likewise, the number of eggs that women have steadily decreased over the years. So it shows that there's a general reduction in fecundity. People are less fertile than they were decades ago. And a lot of this has been linked to these EDCs. These are historical landmarks in EDC research. And you can see how far endocrine disruptors research has gone. It's almost like 60 years now. And you can see the various landmark research findings from 1962 to 1971 to 1991. And then finally, just about 2 decades ago, the WHO issued their first global assessment of the state of the science of endocrine disrupting compounds. And a few years later, we started to have new terms such as obesogens, referring to endocrine disruptors that promote obesity in those who it has been exposed to. And more recently, people have suggested that it shouldn't just be endocrine disrupting substances, but it should be metabolism disrupting chemicals because of the effect that these EDCs have on diverse aspects of the metabolism of the individual, including cancers and metabolic diseases. So, what are the 3 Ys of endocrine disruptors? So we're saying that what are the 5 Ws of endocrine disrupting compounds? Well, first of all, we should know what are they. Why should we be concerned with them? Why are they increasing in their number? What should we do to reduce their effects? When should we do them? Which agencies should be in charge of this? And what role do I play in my development of these problems that are related to endocrine disruption? So how do EDCs work? First of all, the endocrine disrupting compounds, they could either mimic a particular hormone, meaning that their structure may resemble one of the natural hormones, or they could block a hormone, meaning that they have an ability to work on the target of some hormones, thereby blocking its binding to its receptor. or they could actually alter hormone levels, meaning that they can directly stimulate some hormone-producing cells or stimulate the hormone-releasing chemicals or hormones. So these are different ways how these endocrine disrupting compounds work. Examples and sources. There are so many of them, but as I said, we'll just take a few broad groups and look forward to you doing some research on them. One of the most studied ones, as I mentioned, is the bisphenol A. This is found in some plastics, found in resins for food containers, and they lead to a lot of obesity, diabetes, and infertility due to their diverse effects on the adrenocorticotropic axis, their effects on insulin secretion, their effects on LH and FSH. So that is bisphenol A. So if you are using plastic, know that you may have been exposed to it. And that is why many countries now are moving from synthetic materials such as plastic and are going into reusing bottles and reusing or using organic material to do containers for food or for bags and so on. Another one is the pesticides. We've given you examples before of the DDT and organophosphates. We do know that DDT has profound effects on the adrenocorticotropic axis, and high doses of DDT can actually destroy the adrenal gland. It could also cause male infertility, and it has been implicated in some cancers. So these are the effects of pesticides, which may contain DDT, organophosphates, and other compounds which can alter the hormonal balance. Others include phthalates. Phthalates are found in cosmetics, perfumes, some plastic packaging, and they lead to a reduction in fertility or fetal wastage, meaning that more development of miscarriages. We also have parabens, which are used as preservatives in cosmetics. So those of you who are addicted to cosmetics, remember that it can contain a lot of endocrine disrupting compounds. Also, industrial chemicals such as PCBs and others related to this, flame retardants, which can contain fluoralkylating substances, and then dioxins, which are commonly used in herbicides and paints. So you can see that the sources of these EDCs is, throughout life, throughout health, throughout family, throughout work. Who doesn't use cosmetics? Who doesn't get exposed to plastics? Who doesn't have a food container? Who doesn't breathe the air that has been treated with pesticides, herbicides, and others? So all of these can occur with endocrine disrupting compounds. There are so many others. I told you that there are thousands, but we can't go through all of them. It's just for you to know the broad groups. We have the polychlorinated biphenyls. We have the polybrominated diphenyl esters. We have atrazine. We have arsenic. We have triclosan. We have lavender oil. We have tea tree oil. And we have phytoestrogens. All of these can be found in different fragrances, cosmetics, soaps, industries, and so many others. Triclosan, for instance, is a very common compound in those that use cosmetic soaps. And then lavender oil, which people use for their children, can lead to gynecomastia in male children and precocious breast development in females. So all of these are the wide effects that you see in all of these endocrine disrupting substances. You might say, no, well, I watch what I eat, I watch what I drink, but probably you are eating soya beans or you are taking soya milk. That also has been implicated. as it contains a high amount of phytoestrogens, which can affect you. So what are the routes of exposure? The routes of exposure are either by ingestion, for instance, contaminated food from plastics, from polythene wrappings, from all types of things, from water, because water sources are also usually contaminated by industry, or from breast milk. A mother is exposed to endocrine disrupting compounds. She absorbs them, and then she breastfeeds her child, and it moves from mother to child. Also, others include dermal contacts. So for those who are applying these cosmetics and daily care products, some particular types of clothes and material can also contain some of these EDCs. Also, your source of air can also determine how much EDCs you get exposed with. If you are close to industries that are emitting great amounts of this poisonous vapor, you can be shortchanging yourself in the area of your endocrine system. So what are the effects of endocrine disruptors? As we said earlier, fertility is declining worldwide. Also, the age of puberty is getting lower. Nowadays, you see 7-year-old girls, 8-year-old girls who are already pubertal. And that has far-reaching implications. We have increased obesity risk, which leads to increased diabetes risk. We have premature deliveries, miscarriages, and then cancers of the breasts, prostate, vagina, uterus, and so on. All of these can be the effects of endocrine disrupting compounds. So you must have a high index of suspicion when you are evaluating patients that have hormonal abnormalities. With all of this in mind, what therefore can we do? A few decades ago, with the widespread use of DDT, the impacts on human health were quickly discovered. And people started finding that there are so many hormonal changes, there are cancers that were occurring. And for that reason, health authorities swung into action with advocacy, and they pushed till DDT was banned. The governments of most nations therefore barred the use of DDT. And BPA was banned in most countries, and in others, there are labels for food, for water, for toys, and so on that tells whether there is BPA in those substances. We do encourage babies to be breastfed, although we stand another risk there because a few women who have high doses of endocrine disruptors in their system as they are breastfeeding their child, they are transferring such to the children. But generally, by and large, baby-friendly initiative is one that helps to reduce the effect of endocrine disrupting compounds, which are common in pacifiers, common in containers, plastic containers, and other materials that are used, feeding bottles that are used to feed children. So toxicology studies and disease patterns need to be regularly checked. If you have seen a particular condition in your community over and over again, much higher than it used to be, then you have to start searching, you have to investigate to find out what is responsible for this change in disease pattern. You need to check various toxins, you need to check data records to look at the various disease patterns, and then determine whether there is a cause and effect relationship between a particular entrant into the environment and the manifestation of diverse diseases. How do you limit the exposures to endocrine disrupting compounds? Use fragrance-free products. Be careful about your cosmetics. Wash your hands frequently before eating. Rinse your food. Cooking, don't say I cook before. You wash it before, but you left it in the kitchen, and the chemical dust will come to the use of pesticides, herbicides, organic solvents. Learn to be careful the food you consume because they have acid and some are contained in the animals in the sea, and when you use those animals, you actually over disease stuff. Avoid food, lots of produce. nearby can settle in. If you have the fund, install filters to filter the air that comes into your house. In summary, there are thousands of endocrine disrupting compounds. They are ubiquitous in modern living conditions. They have far-reaching effects on occurrence of endocrine and metabolic diseases, and they are also implicated in certain cancers. There needs to be a concerted awareness and concerted efforts to mitigate the effects of these endocrine disrupting compounds. Prevention remains the key, and coupled with regular surveillance and legislation against the use of these endocrine disrupting compounds. These are some of the references that you can check to know more about endocrine disrupting compounds. And with that, I will be on ground for 5 to 10 minutes to take your questions. Over and out.
So thank you so much, Prof. Olufemi Fasomade, for that well-delivered, excellent presentation, sir. So at this point, before we entertain questions, let me just give a short summary of all he has said. So he spoke on endocrine disrupting compounds, which he termed EDC. Is a chemical that interferes with body's hormone and endocrine system. And unfortunately, this is found in most of everything we use for our daily use, the plastic, the pesticides, our cosmetics, water. And he spoke on one of the most studied endocrine disrupting compounds, which is bisphenol A. And he also mentioned other compounds known like paints, livestock. If the chicken you are buying from the supermarket has been injected with endocrine disrupting compounds, by the time you eat them, you are taking them. If the fruits you take, apples, pineapple, vegetables, banana, has been affected, by the time you consume them, then you are exposed. So he talked about how transmission can also be from mother to babies if the mother has it and is secreted in the breast milk, the child can be exposed. So he talked about the effect of this can affect reproductive health. Is one of the leading causes of low libido, low sperm count, low egg count in currently, metabolic disorder, obesity, diabetes, dyslipidemia, hormonal imbalance, and he talked about different routes to which this exposure can occur. And one of the striking one is through inhalation. So those people that have rented houses close to petrol station or close to some dangerous areas where there's endocrine disruptors, I think you should be planning to check out from that accommodation. So he talked about also the 5 Ws of endocrine disrupting compounds. He talked about the why and he talks about how we can reduce exposure. And one of the striking things he talked about is avoid use of plastics in microwaves. It's so paramount and is a practice that is everywhere in all restaurants, even in homes, that they want to warm your food and they will just put it in the microwave with the plastic. So we need to really cut this. So we want to really appreciate Prof. Fasomade for this well-delivered lecture. And at this point, we'll entertain questions, comments, contribution. So if you have a question, you can drop it in the chat box or you can raise your electronic hands, to ask your question. Thank you very much. So it's question time. So we await questions, okay? Thank you, Dr. Ifeoma. Dr. Ifeoma wrote on the comment chat box that, thank you, Prof, for the lecture. Is there a way one can investigate a patient suspected to has been exposed to EDC or make a diagnosis of infertility possibly due to endocrine disruptors? That's the first question we have. I think we don't have another question yet. Maybe, Prof, you can please address this question for us. Thank you, sir.
Okay, thank you very, very much, Dr. Ifeoma. Yes, during the workup of patients who are going for infertility, they do bear in mind all of these endocrine disruptors. For instance, in some IVF clinics, they even send the patient to go for a round of detoxification. We call it detoxification. And the aim of that detoxification is to take out as much heavy metals as possible, as much endocrine disrupting compounds as possible. And usually in the counseling of people who are going for assisted fertility procedures, usually both these spouses, both the husband and the wife, are told to avoid things like perfumes. Why did they say they shouldn't come in with perfumes on the day of egg retrieval, egg transplantation, and all things? Can you hear me? To use all
yes,
those.
Yes, sir. We can hear you now. Yes, sir.
Okay. I said usually in of infertility, women who use a lot of makeup, who use a lot of perfumes and cosmetics are told not to use them during that period, both the period of egg retrieval and the period of embryo transfer. You will find out that the workup includes avoiding all forms of perfumes, even all the people that do the procedure, the gynecologists, the embryologists. The area is devoid of perfumes, devoid of sprays, insecticides, and even some of them use HEPA filters just to make sure that you reduce the amount of endocrine disruptors in the environment. Also, you find out that some of them are sent for a toxic panel to see whether the person has heavy antimony, mercury, and other potential endocrine disrupting substances in their system. But unfortunately, because many of these environmental toxins, they are diverse and they are very expensive to test for, you find that they are not included in the usual panel of tests that patients going for fertility treatment are recommended to have. Let me see. Is there any other question in the
there are still
chat
some
box?
questions. Dr. Isiarwe, she talked about what are the substitutes that are available to replace plastic. Yes, sir.
Okay, yes. So what are the substitutes that are available to replace plastic? The safest porcelain plate, regular plates, the first thing to use in the microwave. But curiously, some people now put a plastic covering on top of the food again. So that defeats the purpose. So the best thing to do is to use porcelain plates, Pyrex plates, and then the other things that you could use are, there are some plasticware that have been certified safe for use in the microwave, and you will see it written in very small letters. If you have a plastic container like those ones you use when you go to buy food, and you don't see any special insignia on it that it is microwavable or it is safe for use in the microwave, do not use. So it's better to take the food out of that plastic, put it in a plate, and slot it into the microwave. The next question I'm seeing here is that are there examples of compounds or foods that normalize or improve the endocrine function to possibly counteract or regulate the effects of these endocrine disruptors? Yes, there are such foods. And that is why you find out that people, again, who are going for fertility treatment are usually put doses of antioxidants. They are put on vitamin E, they are put on alpha tocotrienol, put on hydrogenated water, different things, just to reduce the effect of these endocrine disruptors. Also, in lifestyle, the people are told to take a lot of fruits, a lot of water, and all of this is all in an attempt to flush out excessive toxins, excessive heavy metals, or any other endocrine disrupting compound, and have sufficient antioxidants to neutralize others. Another person is asking, are there any genetic predisposition to those patients? Any genetic predisposition to those patients with endocrine disruptors? Well, there are people have different tolerance to the endocrine disrupting compounds, and what might affect person A may not affect person B. It all has to do with the antioxidant system of each person to some extent, and also how much free radicals you have from different sources circulating in that person, and the natural combatants against these free radicals and these endocrine disrupting compounds. Like we have in every human being, the rate of metabolism differs. So where some people are exposed to environmental pollutants that may cause a lot of disruption in person A, it might not cause a lot of disruption in the second person. So, and remember that endocrine disruptors can be very, they are, sometimes they may have positive effects and sometimes they may have negative effects. For instance, people that have hyperfecundity. If there is a community, I think in Oyo State is Igbora, which is said to be the twinning capital of the world. It's likely that it is not just genetic, but it is a likely result of the endocrine disruption that comes from the plenty amount of phytoestrogens that the women there consume. Some feel that it is from their yam, some feel that it is from other food substances in that area. So that is an endocrine disruption that leads to hyperfecundity. As we have there, we can also have other endocrine disruption that leads to infertility or precocious puberty or premature puberty or delayed puberty and so on. So they are different, and in each area, every endocrinologist needs to look at the pattern of disease in his area. For instance, if you are seeing so many girls coming with premature puberty, you have to start thinking that these people are not related and they are all having this problem. There must be something in the food they eat or the water they drink. Also, if you have an area where you have plenty of goiters, that is a simple form of endocrine disruption. If you have people consuming a lot of cyanide-containing tubers, yam, cassava, and they are not taking sufficient antioxidants through and enough iodine, you have a situation whereby these substances, which include lotaustraline and other cyanide-containing compounds, they disrupt the endocrine system, and the person now starts to develop goiter, and you have that area being an endemic goiter zone. So it's not only iodine deficiency, it could also be poisoning through cyanide from the food that the people do take. Thank you.
Yes. Thank you so much, Prof. Fasomade, for that very lucid answers. And I believe all the questions are well answered. And thank you, sir, for taking out time to be part of this pre-conference update. We really don't take the opportunity and the sacrifices, for granted. We are really grateful. Thank you, sir.
You're welcome. Thank you. It's a pleasure being here.
Yes. So we'll be moving to the next presenter, who is already ready for the presentation. And the next presenter is Professor Abraham Oshunubi. He's going to talk about animal rights. So it's not all chicken or all rabbits or any animal you see you kill, you can actually be jailed for that. So because these animals now have a right, even the mice and all the rest, they have a right. So you can't just pick any animal and hold into ransom. So Professor Oshunubi will be talking about animal rights, and I'll just give a short citation as regards Professor Abraham Oshunubi. Professor Abraham A.A. Oshunubi is the Dean of the School of Postgraduate Studies and the Chair of the Medical Consult Board at the College of Medicine of University of Lagos, CMUL, as the Dean of the Postgraduate SBGS, which is a postgraduate Studies and chair of the MEDILAC Consult Board. He has redefined postgraduate education and research leadership. His pioneering role as the executive director of the University of Lagos Business School underscores his unparalleled ability to spearhead institutional growth and development. Professor Oshunibi is an entrepreneur and organization strategist. He currently serves as the lead facilitator for leadership and organization behavior at the University of Lagos Business School. He's a business, health, and stress management coach. He developed the 21-point action plan for perfect health. He's a member of the Governing Council of University of Lagos and a graduate of the National Institute for Policy and Strategic Studies, Kuru. Ebab Oshunibi has his MBBS degree from University of Ibadan in 1987, his MBA from Ahmadu Bello University, his MSc and PhD from University of Lagos. He was the founder, chief Okay. So sorry for the break in transmission. I think we are right back again. Thanks for your patience. So let me just quickly complete. So he's a accomplished reproductive endocrine anatomist and is a fellow of American College of Endocrinology, a passionate and innovative education. He champions teaching innovations and is the Professor Oshunibi influence transcends the classroom. In 2010, students of College of Medicine like voted him the most positively influential male lecturer, a testament to his impact as an educator and mentor. His research prominence was cemented when he ranked among the top 2% researchers in Nigeria and Africa in the World Scientist Ranking in 2023. Please join me as I welcome Professor Abraham Oshunubi to take the topic animal rights in this pre-conference update course. Thank you, sir. Sorry, it soon be on.
Good day. We'll be looking at the consideration for animal rights in research. I am Abraham Oshunubi, Professor of Anatomy, University of Lagos. Outline of our interaction is this. We look at introduction, historical perspectives, importance and benefits of animals in biomedical research, when to use animals in research, research conditions for animals, animal anesthesia and surgical procedure, animal rights and ethical considerations, choice and number of animals for study, alternatives to animal experimentation and extrapolation from animal experimentation. The learning objectives. By our interaction, we should be able to state the scope of animal experimentation, state the reasons, benefits, advantages, and disadvantages of animal research, cite guidelines to be met before undertaking animal experimentation, give the conditions under which animals should be kept, explain the standard principles and their application, explore alternatives to or modifications to animal experimentation, and draw the line between justification and extrapolation. This is one of the two papers I wrote here earlier on, the use of animals in endocrine research, a synopsis. You can find it in the Nigerian endocrine practice. It should be online. And the second is titled Animal Experimentation, Contemporary Ethical Consideration, published in the Journal of Anatomical Sciences. So these two articles actually talk a lot about what we are learning today. Introduction. Animal testing is the use of non-human animals for the purpose of scientific experimentation. Please underline non-human animals, which shows that these animals have a lot to do in terms of similarities, relationship to humans. Synonyms include in vivo testing, animal experimentation, animal research. Great teachers and dependable partners. Yes, great teachers and dependable partners. But I like to tell a story, a short story titled, to start with, titled The Little Rabbit That Saved Lives. Years ago, a young researcher was assigned to work with rabbits for a critical study on diabetes treatment. One morning, he noticed that one of the rabbits was trembling in the corner of his cage. Instead of rushing past, he paused, gently picked it up, and comforted it. He spoke softly and made sure it was warm, fed, and calm before beginning his work. Over time, he realized that when he treated the animals with kindness and respect, they responded better, less stress, more reliable, and healthier conditions. Research. The data from those studies went on to contribute to life-saving treatments for patients worldwide. At a scientific conference years later, he shared this simple truth. I quote, "The greatest breakthrough often come not only from our science, but also from our humanity. When we treat animals with respect, care, and love, we honor the trust they unknowingly place in us, and we ensure that our research is both ethical and impactful." Lesson for researchers, please. Every animal is not just a subject, but a silent partner in discovery. Treating them with respect, care, and love is not only an ethical responsibility, it also improves the quality and integrity of science. Now let's look at this data on the use of animals in research. Currently, about 60% of animals we use are mice. These are specially bred laboratory strain. 14% now currently are fish. Okay. However, zebrafish are the most common of the fish that we use. And 9% of the animals that we use are rats. 3% are bears, mostly quail and poultry. And then 2% constitute other rodents and rabbits. Okay, it is noteworthy that we also use non-human primates, such as monkeys. However, great apes such as chimpanzees or orangutan, gorillas have been banned in most countries worldwide. In most countries. Okay, it is noteworthy to mention that fish and birds, okay, have now witnessed actually massive increase in the numbers of fish and birds that we now use, okay, for research, for animal research. This is really very important compared to what we had a few years ago. So fish and birds are now coming into the front line as animals of choice in research. Now, some historical perspective. Let's look at this historical perspective. Okay, use of animals in scientific research has a long history dating back to the 5th BC. When scientific dissection and vivisection of animals would have begun by then by Alcmaeon of Crotona in Italy and Empedocles, okay, in Sicily. Galen also worked extensively on animals. However, the first observations of significance to modern science were made in those 1600s when William Harvey used animals to observe and describe the blood circulatory system. This was one of the greatest research then on animals, and it is noteworthy to mention that. Now let's look at something more, something very interesting now. The discovery of insulin. Paul Langerhans, a German medical student, identified importance of pancreas in the early 19th century and discovered a group of cells that would later be known to produce insulin. In 1869, Langerhans found that within the pancreatic tissue that actually produce digestive juices, there were clusters of cells whose function as at then was unknown. Okay, it is noteworthy also to mention that Marin and Oscar Minkowski in 1889 discovered the role of pancreas in diabetes. They found that dogs whose pancreas was removed developed all the signs and symptoms of diabetes and died shortly afterwards. In 1910, Sir Edward Albert Schaffer found that diabetes resulted from lack of insulin. Okay, now let's go on with the story of insulin discovery. The quest to understand and treat diabetes led to one of the most remarkable medical breakthroughs of the 20th century, and that is the discovery of insulin. I love to talk a lot about this discovery. In 1916, a Romanian scientist named Nicolae Polescu, yes, Nicolae Polescu, developed an aqueous pancreatic extract, which is called pancrein. Yes, pancrein. When injected into a dog with diabetes, this extract was found to normalize blood sugar levels. Polescu's pancrein was derived from the bovine pancreas, prepared in salt water and purified with hydrochloric acid and sodium hydroxide. Unfortunately, his research was interrupted when he was called to serve in the Romanian army during World War I, and he only returned to his work in 1921. Meanwhile, In 1921, at the University of Toronto, the Canadian surgeon Frederick G. Banting and medical student Charles Best embarked on their own investigations. They extracted material from the pancreas of dogs and demonstrated that it could prolong the lives of diabetic dogs by lowering blood sugar. Their groundbreaking work formed the cornerstone of modern diabetes treatment. This project was conducted under the oversight of Professor MacLeod, a Scottish physiologist who provided laboratory space, guidance, and scientific input. To refine the extract, however, for human use, James Colley, a Canadian biochemist, and they succeeded in purifying insulin, making it safe and effective for clinical application. The name insulin was proposed by MacLeod, okay, who adapted the earlier term insulin suggested by the British physiologist Edward Shapley-Chafffer, who was one of the first scientists to hypothesize the existence of a pancreatic hormone regulating blood sugar. It's important to also mention that in 1923, the Nobel Prize in Physiology of Medicine was awarded to Banting and MacLeod for the discovery of insulin. This decision sparked controversy. Banting felt that Best deserved equal recognition and therefore shared half of his prize money with him. Similarly, MacLeod acknowledged the indispensable contributions of Colley, the biochemist, sharing his own prize money as well. So the discovery of insulin is very, very interesting. Now let's look at the importance and benefits of animals in biomedical research. Throughout history, scientists have been solving medical problems, developing new techniques and treatments, curing diseases, all by using animals in biomedical research. Virtually every major medical advance of last 100 years and more has depended on research with animals. Animal studies have provided scientific knowledge that allows healthcare providers to improve the quality of life for humans and because of biomedical research, both humans and animals now have life-saving medicines, cancer therapies, organ transplantation, even vaccine, safe consumer products, treatment and cures for countless other medical disorders and diseases. Scientists have developed many valuable non-animal models. Yes, non-animal models. So we need to look at reasons for using animals in biological research. Yes. Okay. Those scientists have developed a lot of models that are non-animals in nature. However, these models cannot imitate the complicated processes that occur in a living system. Because when you use model, you are likely going to not take into consideration the complexity of the processes that are taking place in a living system. Animals are similar to humans and are good models when humans cannot be used. Animal life is based on the same genetic, biochemical, and physiological principles as human life. So organs and body systems, they are quite similar. So these are some of the reasons why we use animals in biological research. Short lifespan, yes. yes, relatively short lifespan, allows animals to be studied throughout their entire lifespan. For example, it is quite easy for a human scientist to actually study several generations of animals, which this may actually be impossible for a single scientist to study several generations of live humans. So environment can easily be controlled and kept on the view. So what this basically means is that we can modify, we can manipulate the environment under which we keep experimental animals for the purpose of what experiment we are using them for. Again, genetic linkage studies in humans are always hampered by need to collect a large number of families. Maybe this is even more important, that reliance on whatever pattern of mating that has occurred within the population. Genetic heterogeneity is important, and concerns regarding paternity. Let me explain this. When we do genetic studies in humans, where paternity is based on what the respondents, what they tell us, okay? However, the paternity of animals cannot be in doubt because they are kept under they are under our observation. So it is as against that of humans, is whatever the respondent the respondent is whatever they claim in their paternity. That is what unlike animals that we can be 100% sure of their paternity. In terms of diseases, yes. In terms of disease susceptibility, animals are susceptible to the same diseases that affect humans. For example, allergies, arthritis, bad defects, cancer, tuberculosis, asthma, epilepsy, heart diseases, kidney diseases, Lyme, ulcer, all glaucoma, diabetes, bronchitis, all these diseases also affect animals. So we can actually study a lot of these diseases also in animals. So when to use animals in research? Number one, following literature searches and analysis of data of previous research. So before you start animal research, you must study the literature very well. You must analyze data from previous research. Next, you must also follow extensive training. You must have gone through some training. You must have gone through some education on the use and handling of animals. This is really very, very important. You should have done some computer modeling, because sometimes some computer modeling can serve as alternatives. You could also have done some simulations, okay? And that means you consider this as a credible alternative before you go into animal research. You can also use animal when you have also considered that you can't use cell or tissue culture as alternative that have been explored. Then you must follow the institutional animal care and use committee approval. Yes, you must get the approval of this committee. Every institution that their researchers use animals for research actually have this committee. Also, you use animals research before human clinical testing. Sometimes you also do that. Okay, now let's look at human responsibility. Use of animals in research is a privilege, ladies and gentlemen. Let me take that again. Please, ladies and gentlemen, use of animals in research is a privilege granted to those investigators and programs that commit to meeting the highest ethical regulatory standards. Ethical treatment of animals implies animals used in experiment should be treated well. The experiment as well that you are carrying out must also be monitored by the institutional animal care and use committee. Ethical treatment of animals also include providing animals with comfortable living environment. You must also minimize comfort from testing. You must treat them nicely, and when they have diseases that is no longer compatible with life, you must humanely euthanize these animals. Now let's look at the Sundowner principles. These principles were articulated by the National Aeronautics and Space Administration, NASA, in late 1996. And these have become the gold standard, okay, for the use of animals. Number one is respect for life. Number two, societal benefit. And number three, no malfeasance. And let's look at this in more detail. Respect for life. All creatures deserve respect. This principle requires that animals used in research should be of an appropriate species and health status, and should involve minimum number required to obtain valid scientific results. These are really very important. And selection of appropriate species must also be given consideration. In terms of societal benefit, advancement of biological knowledge and improvement in protection of health and well-being of both humans and animals provide strong justification for biomedical and behavioral research. This tells that where animals are used, the assessment of the overall ethical value of such use include consideration of the full range of potential goals. So that means the benefits that the potential benefits that could accrue from the usage must outweigh all the injuries or all the discomfort that will be caused to the animal. So this is really very important. And thirdly, non-malfeasance, it is important to note that animals feel pain. Okay? They are sentient. Yes, they feel pain. Therefore, please, ladies and gentlemen, it is important that we minimize distress, we minimize pain, and we minimize suffering. And this is, as a matter of fact, a moral imperative. It must be taken into consideration. Unless the contrary is established, investigators should consider that procedures that cause pain or distress in humans may also cause pain or distress in other animals. And therefore, animals undergoing surgery, on animals undergoing procedures should be generally assumed that such procedure will give them pain, and therefore analgesia must be provided. And instead, here we have surgery, prolonged surgery is being done, anesthesia must be provided for such animal under aseptic technique. This is really very important. All surgical procedure, of course, must be under aseptic technique, especially for survival procedures. Even if it is not survival procedure, it must still be under aseptic technique. Anyway, if you don't follow this procedure, you are not likely going to get a good reward for your efforts in terms of research. But more importantly, it is a moral obligation. We must do it. Under surgery, no animal should be made to experience pain or suffering. I must never forget this, death of animals being used. Please, it is important that if animals, for example, have been rendered in such a way that they are incapacitated, or they are going to undergo so much suffering after experimentation, they must be euthanized. they must be euthanized. This is really very important. It is also important that disposal of animals after usage, they must be disposed appropriately. Please do not dump animals after usage anyhow. They must be given final burial right. This is very, very important. It is a moral obligation. It is imperative that they are treated well. Alternatives to animal experimentation. Are there alternatives to animal experimentation? Let's look. Okay, a wide range of innovative methods are now available, by the way, as alternatives, and this must be considered. They should be considered even before starting animal experimentation. Okay, they are now available. Okay, there are alternative, credible alternatives are now available to the use of animals in research and testing. These approaches draw on advances in science and technology, ensuring that studies remain ethically sound while still producing reliable and relevant results. So it means that alternatives should actually be considered where possible, please. One group of alternatives involve physical chemical techniques, microbiological systems, and tissue or organ culture preparations. These methods allow researchers to investigate biological processes without relying on whole animal models. In addition, the growing field of computer and mathematics-based simulation, known as in silico testing, offers powerful tools for predicting biological responses and modeling toxicity. Other valuable alternatives include epidemiological surveys that study patterns of disease in human population, as well as plant-based assays, such as toxicity testing using plant systems. These are very good alternatives to be considered. Modern biological research has also expanded to include more human-centered methods. This includes the use of stem cells, microdosing studies in humans, DNA chips, microfluidic chips. These can also be considered human tissues, and advanced imaging technologies. They can also be considered. Certain human-derived materials have actually proven especially useful. For example, volunteers can actually participate in skin irritancy tests, okay, while donated human blood is valuable resource as well for pyrogenicity studies. Researchers have also developed the modular immune in vitro construct as well, which replicates aspects of the human immune response without the use of live animals. In addition, fungal models are emerged as credible alternatives as well. These are as effective. These have emerged as effective systems for mimicking mammalian drug metabolism, providing yet another non-animal pathway for exploring pharmacological processes. Taken together, ladies and gentlemen, these methods demonstrate that a variety of practical and scientifically robust alternatives exist to reduce or replace animal experimentation. They not only improve the ethical standing of research, but also often provide results that are more directly applicable to human health. argument against in vitro cell culture techniques and in silico computer simulation. This is really very important. In as much as I, for example, I love culture techniques, simulation, computer simulation, but the truth is that all these systems cannot be true alternatives, since these use data from prior animal experiments, while culture cells often require animal-derived products, such as serum. And again, we cannot completely replace animals, as they are unlikely to, all these computer simulations cannot completely, of course, replace animal modeling, because they are unlikely to ever provide enough information about the complexity of interactions that are going on in a living system. Now, let's look at the 3 hours before we end today. Okay, this is really very important. What exactly do we call the 3 hours? Ladies and gentlemen, the 3 hours are a universally accepted ethical framework for the human use of animals in science. They were first proposed by scientists William Russell and Rex Ball in 1959 in their book, The Principles of Human Experimental Technique. The guiding principle here is to use as few animals as possible and to ensure that any use is justified and causes the minimum possible suffering. So what are these 3 R's? Replaced, reduce, and replace. That as much as possible, we can replace animals with other models. We can reduce the number where we were using 20 before. If 5 will give the appropriate result, so be it. So we need to reduce the number. We need also to refine by considering reduction in the number or the replacement, okay, with alternatives to any procedure that causes pain. So we must constantly refine our procedures in order to reduce pain and distress to animals. So these 3 R's are not just ethical ideas, ladies and gentlemen. They are embedded in the national and in the international legislation of most countries. Any research institution that uses animals must have an ethical review process that ensures applications for projects strictly adhere to the 3 R's principle. In essence, the 3 R framework ensures that animal research is conducted only when there is no alternative, with the utmost consideration for animal welfare. In recent times, we are also adding the 4th R, which is actually responsibility. The essence of responsibility is to say that, look, we should act responsibly. And this responsibility, for example, involves also what we call rehoming. That is, it is the responsibility of the researcher to ensure that animals are returned back to their home after the experiment, if the experiment is compatible with life. So this is really very important. We call it the rehoming. This is a very important part of the 4th R, responsibility. So it's a responsibility to find suitable homes for animals that are healthy and behaviorally sound after participation in experiments. Lifetime care is also important for these animals. It's part of the responsibility, part of the 4th R. So how do we choose animals to study? Based on diseases of body system, based on animals that more similar to humans, animals that have been used in the past. So based on previous research, transferability of information as well. Genetic uniformity of the organism is also important. Background knowledge of biological properties, cost and availability. All these are part of what will guide us in the use of animals. Generalizability of our result is important. Can we generalize the result? So that also affects which animals we use. The ease of and adaptability of experimental manipulation. Ecological consequences and ethical implications are also important. Physical size is not always, ladies and gentlemen, is not always the issue. For example, many chimpanzees and monkeys are close to women. However, when you want to study it, these are not likely the best to use, because it has been well documented that many of these animals, for example, the African green monkeys, the sooty manga bees, they do not actually develop. They actually do not progress. It's HIV in them do not often progress to AIDS. So these are not the animals you want to use. Conversely, much smaller animals such as mice or rats can be genetically engineered to mimic human immune responses and are widely used in HIV/AIDS research. So this is really very important. It's not only about size. So the choice of research animals depends on physiology, disease susceptibility, and ethical consideration, not size. The key is selecting the species that provides the closest and most reliable model for the scientific question being addressed. Extrapolation, can you extrapolate? Can you extrapolate? You cannot directly extrapolate, but it gives you some indication from where you are going. Animal models are essential tools to mankind. Animal experimentation has led to the development of procedures and medicines that have improved and saved lives, okay, of both humans and animals themselves, including treatment for cardiovascular disease, diabetes, mental illness, and several animal ailments. Data generated in rats, for example, have correctly predicted the outcome of several human diseases. Nevertheless, ladies and gentlemen, caution must be greatly exercised in extrapolating findings from animal research to humans. As 1 Corinthians 15:39 says, all flesh is not the same. Men have one kind of flesh, animals have another. So, and scientifically, this is also quite correct. The summary is that we must exercise caution with direct extrapolation from animal studies to humans. And as a matter of fact, vice versa, we must also be cautious in also extrapolating from humans to animals. And last line, no. Patient. These principles support several moral rules. Do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense, and do not deprive others of the goods of life. In fact, ensure that every being that interacts with you lives a better and happier entity. Ladies and gentlemen, treat every animal used in research for respect. As a matter of fact, treat every animal, every being with respect, whether in research or out of research. Thank you, ladies and gentlemen.
Thank you so much, Professor Oshunibi, for that well-delivered lecture. It was really apt and well delivered, and we are really grateful for taking out the time to come and give us this lecture. It was really excellent, sir. Thank you so much, sir. So at this point, let me just quickly do a little summary of what Prof. Oshunube has presented. It talked about animal rights, which is animal testing in the use of non-human for the purpose of scientific experimentation. It discussed the discovery of insulin, and it went on to talk about the reason why we use animal in biological research. One of the most important information he mentions because of their short lifespan. He also moved on and said that the reason why we use animal research is because they mimic human diseases, so you can use them for any research that human could have, like asthma, DMTB, and the rest. Another thing he talked about was the Downers principle, to which he said is a gold standard for the use of animal in research, and it entails a respect for life, etc. It talked on the alternatives to use of animal in research, and he went further to discuss the 3 R's, which are very important in for animal universally accepted framework for human use of animal in research. He talked about the replacement, reduction, refinement, and he said the 4th point will be added soon, which is responsibility. And he also mentioned that animal use in research is conducted only when there is no alternative. So when you have an alternative that you use for your research process and we still give a very good result, then you don't necessarily have to use animal for your studies. So these are just one of the main points highlighted in Prof. Oshunubi's presentation. So at this point, we want to entertain questions. You want to entertain questions, comments as regards his presentation, and you can raise your electronic hand. Please, when you are not speaking, kindly mute your mic. There are some questions already dropped at the chat box, and this was asked by Dr. Balarabe, and he says, "Thank you, sir, for the wonderful presentation. I have questions. The first question is, are there differences between animal rights and welfare, or they are the same?" That's his first question. The second question he talked about is, what about dangerous animals like snake, lions? Must their rights be respected in the setting of experiments, considering their violent nature? And the third question is there any legal policy in Nigeria for animal rights, especially in the setting of experiments? I think those are the 3 questions he had dropped, and Prof. Sir, kindly help us address them. Thank you, sir.
Thank you. First, let me acknowledge the fact that Bola has done a great summary to my presentation. Dr. Okunawa, thank you for that recap. You've done beautifully. I think you could have just as given the lecture. You did very well. By the way, animal rights and welfare are different. Animal welfare is not holistic as animal rights. Animal rights is all encompassing. Welfare only talk about, when we talk about welfare, we only talk about amenities, the environment, lifestyle of the animals, but the rights are more holistic in nature, and that's why we prefer to use the word animal rights. And concerning dangerous animals, as far as we are concerned in this world, we are all animals anyway to start with, and we have all been created to live in harmony. I was in India in 2012. A scorpion came inside where we were having a cocktail party. The scorpion wasn't killed because the animal rights in such places, the scorpion was handled with care and thrown back into the wild. So under animal rights, we do not. The important thing here is that every animal deserves a right to live, because you didn't create one, you are not expected to destroy one. That's just it. Whether there are animal rights in Nigeria, well, it's vary from places to places. What most of us have, like in University of Lagos, we have ethical committees that currently takes care of rights generally, but of course, our ecosystem is not as developed as that of South Africa. When I entered the animal lab in South Africa, I mean, I saw the anesthetic machines that we used for had experience of seeing the animal theater in South Africa, KwaZulu-Natal University. Most of the facilities they are even are at par at what is obtainable elsewhere, even in Nigeria, in terms of humans. So from country to country, there are a couple of variations, but yet animal rights must be upheld. And anyway, it's also important to also stress the fact that animals are not usually, as before, the first point of call. For example, there are computer simulation silos that we can work on, skin, and then single cells harvesting, we can do that. So animals should be considered only when you have tried most of the other areas, and then you are not. And one last area I need to emphasize, even though it has been mentioned in the lecture, is when we want to feed after completion of our experiment. Most of the time, we just throw the animals away. We are not supposed to do. Every animal deserves a final burial right. Yes, final burial right. You must dispose them appropriately. They must have their final right. And then when animals have been diseased by our experiment, they must live a long. For example, there are some animals now, you weigh whether you want to be given that. For example, I have a lot of animals I have made diabetic. So I have to weigh whether I need to give insulin for life, or a hypoglycemic agent, or I want to euthanize the animal. So if you know that the quality of life is not going to be that really good, it's better you euthanize such animals. Thank you. Thank you for listening. Thank you for watching.
Thank you so much, Professor Oshunibi, for that well-answered question. We really, really appreciate your presence and for taking out of your very busy day. We really for granted, and we are really glad you came. Thank you so much, sir.
Thank you all. God bless.
Okay, we'll begin this presentation. We have just 2 presentations left to conclude the pre-conference updates seminar. Okay, so sorry for the break in transmission. So sorry. We are back online, and we'll be taking the next presentation. And this presentation is on newer oral agents in the management of type 2 DM, and no other person that is taking the presentation than our amiable president of Endocrinology and Metabolism Society of Nigeria, Professor Uloko, Andrew Uloko. And I'll just quickly give a short citation as regards our amiable president, Professor Andrew E. Uloko. Is the professor of medicine and endocrinology, consultant endocrinologist, and immediate past head of Department of Medicine, Bayo University, Kano, Nigeria, and Aminu Kano Teaching Hospital, Kano, Nigeria. He's an adjunct professor of medicine and endocrinology in the University of Abuja, Nigeria. He's currently the president of Endocrine and Metabolism Society of Nigeria, the past national first vice president, Diabetes Association of Nigeria. He's an IDF certified expert trader in diabetes education. He's a member of several notable research consorts with a PI and co-PI responsibility. He's a board member, Faculty of Internal Medicine, National Postgraduate Medical College of Nigeria. And looking at his scholar activities, he has over 95 peer-reviewed journal publications. He has several chapters in various textbook guidelines, monographs, and technical reports. He's a reviewer to several highly reputable peer-reviewed journals, both nationally and internationally. He's an active participant in the development, writing, and review of diabetes guidelines, a speaker, the presenter at several local, national, international scientific meetings for many years. He has editorial roles, a pioneer editor-in-chief in Kano Med News, a publication of Nigeria Medical Association Kano State Chapter, is the editorial advisor of the Nigerian Journal of Medicine, the deputy editor of African Journal of Endocrinology and Metabolism, which is our dear journal. His current research interest is in diabetes, epidemiology, diabetes and the heart, diabetes education, obesity, and related disorder. Some ongoing research and co-investigation and site IP is into the cardiovascular risk assessment and education, impact on risk reduction in African people with type 2 DM, which is the CAD-RED-RAD study. It's also the cardiovascular risk in diabetes study, the CAT study, the real-world safety and tolerability experience of empagliflozin with or without metformin in patients with type 2 DM, the E study. Also, he has received multiple awards in both several reputable organizations and institutions. You can see that our amiable president has many caps and his hands are very full. So please join me in welcoming our president, Professor Andrew Uloko, as he takes on the topic, neural oral agents in the management of type 2 diabetes. You are welcome, sir. You are welcome, sir.
Thank you very much for the kind introduction. Our indefatigable chairman, scientific subcommittee, Dr. Bolanle Okunowo. I want to start by appreciating everybody for waiting until this late evening to listen to my talk. I am going to be as fast as I can, knowing that you are tired and your assimilation rates for this the topic I have been assigned to talk on is newer oral agents in the management of type 2 diabetes mellitus. I want it on a slideshow, sorry. I'll put it on a slideshow. Okay, thank you. So, the outline for this talk will be to briefly look at the burden of diabetes, and then to talk some bit of pathophysiology, and then we go down to medications for the management of type 2 diabetes, and then we will take home. You already know that diabetes is a raging epidemic affecting some 589 million adults globally. And at the moment, it is estimated that if you see 9 people, one of them has diabetes mellitus. There is a projection that this will be much higher in the coming 20 years thereabout. In Africa, there is an estimated 25 million persons currently living with diabetes mellitus. But some of us challenge this figure as a gross underrepresentation of what the true picture is. But the latest IDF Atlas has it that 25 million Africans live with diabetes. And in one particular year, in 2024, some 3.4 million deaths were attributable to diabetes mellitus. This is translated in some way to one person dying every 6 seconds. And this is quite alarming. And I think it should give us cause for concern. In terms of the economic implication for the management of diabetes, over a 17-year period, there has been a 338% increase over what is expended in the management of people with diabetes and diabetes-related conditions. And this translates to about $1 trillion US. But the question I ask is, if you spend $1 trillion US in the management of diabetes, which part of the world are you talking about? Certainly not in underdeveloped countries and developing economies like Nigeria, where resources are restricted for the care of non-communicable diseases, particularly diabetes mellitus. So in Nigeria, we presently estimate that some 6 to 7% of our population live with diabetes mellitus, accounting for about 12 million individuals. And there is the heavy presence of the prevalence of risk factors for diabetes mellitus type 2, most of which are issues about lifestyle, urban dwelling, unhealthy diet, physical inactivity, obesity, overweight, and then the role of advancing age. We also looked at the distribution or the prevalence of diabetes across zones in Nigeria. And what turns out is that the South-South zone is leading Northeast and then the Southwest. This study, I must say, has been replicated recently by Olamayogun et al., and their findings are quite similar, with just slight increase in the prevalence figure. Let's then look at pathophysiology. This becomes important because you couldn't discuss pharmacotherapy without recourse to pathophysiology. And so just to remind us of what we already know about type 2 diabetes, that there is the combination of several factors leading to sustained hyperglycemia. Recall that you define diabetes mellitus as sustained or chronic hyperglycemic states. And some of these factors prominently include relative insulin deficiency resulting from beta cell dysfunction, and then an imbalance which favors a hyperglucagonemic state and then an insulin resistant state. Now, think about insulin resistance taking place at the level of the peripheral tissues, the muscles, the adipose, where glucose disposal is impaired. And think about impaired hepatic glucose output with increase in hepatic glucose output stemming from increased gluconeogenesis and glycogenolysis. Also think about an impaired incretin effect. When we talk about incretin effect, we talk about peptides that are gut active, that have modest insulinotropic effects. And if these peptides are in diminished supply, you have an imbalance in metabolism and hyperglycemia can ensue. Then there is the role of the central nervous system. And it is yet to be fully understood as to how this contributes to sustained hyperglycemia that we see in people with type 2 diabetes. And we think that insulin resistance that you see everywhere also affect the brain. and this can result in hyperglycemia in its own way. So why do we bother to talk about this? I have just quickly superimposed the different pharmacotherapeutic agents that are used currently in the management of type 2 diabetes over the different aspects of pathophysiology that I have just narrated. In the course of our next discussion, we will be dwelling more into some of these agents, and we will see. The talk about pathophysiology of type 2 diabetes will be incomplete without reminding ourselves about the natural history of type 2 diabetes, starting from a normal glucose tolerant state to a pre-diabetic state represented by impaired fasting glucose and impaired glucose tolerance, where you see a gradual increase in insulin resistance. And to match that insulin resistance, you have the beta cell functioning excessively beyond what they should do. So there is a state of insulin resistance that is rising, and then there is a state of hyperinsulinemia. This, at least in the pre-diabetic state, will attempt to compensate for each other, so that if you do evaluation or if you do a fasting plasma glucose at this time, you are likely to get a normal blood glucose value, and that does not exclude the presence of diabetes or pre-diabetes. So we encourage that a standard evaluation, if you want to know whether somebody has diabetes or not, should involve a glucose challenge test or a glucose tolerance test. At the time of diagnosis, we have insulin resistance that plateaus and remains there throughout the lifespan of the individual living with diabetes. But beta cell dysfunction becomes more prominent, and with the loss of 50% of beta cells, and then this loss of beta cells continues relentless, irrespective of therapeutic agents that you have put on board. So the person that is going to break grounds in terms of discovering a cure for diabetes should be able to provide remedy that will halt or stop the relentless loss of beta cells that is typical of type 2 diabetes mellitus. Now, as a herald to blood glucose lowering agents, we will have to briefly look at some historical perspective. I like the emphasis. Today, you must have heard a lot from the groundbreaking research efforts of Martin Best MacLeod, and this led to the discovery of insulin in 1922. And several modifications, several entrants to this discovery had followed over the subsequent many years. So in the last century, to date, we have seen the evolution and the development of pharmacologic agents that address the management of type 2 diabetes mellitus. Some notable inputs include by 1955, when by serendipity, sulfonylureas were discovered, and then by 1957, when biguanides were discovered. At that time, fenformin was a prominent one, but was rapidly withdrawn because of troublesome lactic acidosis at that time. In the following years, there was the discovery of alpha-glucosidase inhibitors, and this was approved by the FDA in 1995. And then by 1997, the TZDs, the thiazolidinediones, came on board. And then by 2005, 2006, we had the entrance of the incretin-based therapies represented by GLP-1 analogs and DPP-4 inhibitors. And so the key turning points for the use of oral blood glucose lowering agents was the first orally active anti-diabetic agent, sintalin, that was a derivative of guanidine that was introduced in 1926 by Frank, who was a German scientist. And then in 1957, like I mentioned earlier on, fenformin came on board. And then a number of new classes of anti-diabetic agents were introduced subsequently with the entrance of non-sulfonylurea secretagogues and alpha-glucosidase inhibitors. What then are the medications used for the treatment of type 2 diabetes mellitus? I would like to use this as a summary slide to capture most of the classes of oral agents used in the treatment of diabetes type 2. We have the traditional ones, and then we have the ones that have just newly come on board. The biguanides represented by metformin. I'll not be speaking much on that. You already know it because the topic I am assigned does not permit me to go into details of that. The sulfonylureas, the meglitinides or the glinides, which also work similar to the sulfonylureas. As a matter of fact, we'll be discussing the glinides in some detail later on. The alpha-glucosidase inhibitors, which are prandial regulators working on the brush border of the small intestines to prevent the absorption or reabsorption of glucose. The TZDs or the thiazolidinediones that work intranuclear, shaping adipose topography and making insulin more sensitive to peripheral tissues. This class, unfortunately, ran into problems in, I think, around the year 2006, 2007, when they discovered rosiglitazone had issues with the heart, and it was withdrawn. And then pioglitazone, which is still existing, but limited in use in just very few countries. Then the era of the incretin-based therapy, GLP-1 receptor agonist, but exists mainly as injectable forms, even though we know that there are formulations of semaglutide that can be used as oral agents, and then the DPP-4 inhibitors, which we'll be discussing in some greater details later on. And then quite recently, the sodium glucose co-transporter 2 inhibitors that work via the renal pathway. The profile of all these medicines used in the treatment of type 2 diabetes is represented in this busy table. The table is color-coded. I'm not going to go into the nitty-gritty of this, but there are facts that you already know, that you already have. For each agent matched against the effect or the characteristics, you could have fewer adverse events or possible benefits represented by a green color, or the yellow color representing some caution if you want to use this agent. And then the red color, of course, danger, representing adverse effects. So for each of the agents here, these color-coded boxes will describe what happens in greater details. For want of time, I'm not going to go into the details of this, but my material will be made available through the organizing committee at the end of this talk so that you could read through at your own time. Should you have reason to place patients on oral hypoglycemic agents, it is important that you have some form of algorithm or protocol in assessing patients, profiling the patients, determining whether the patient is severely glucotoxic or the patient is moderately glucotoxic, and then deciding whether you want to go through the insulin route if the glucotoxicity and diabetic emergency is apparent, or you want to go through the conventional route by giving the patient oral hypoglycemic agents. And now, what choice of oral hypoglycemic agent depends on the patient profile. We are now gradually shifting away from the old paradigm that first-line treatment for diabetes type 2 must be metformin. We now know that if you profile your patient properly, depending on the presence or absence of atherosclerotic cardiovascular disease, heart failure, chronic kidney disease, obesity, and so on, metformin may not be first-line treatment, even though a few guidelines still retain metformin as first-line treatment. I've just made a list of what oral hypoglycemics are on this slide. Now, this has given me a good ground to launch or dive into newer oral hypoglycemic agents. And these are listed on this slide. The year for which they got FDA approvals have also been indicated in bracket in front of all of them. I'm not going to go through all of this now for want of time, but we will be discussing the individual molecules as we proceed. Note that vildagliptin, as of the time I was preparing this material, does not have FDA approval. Why it is so, I don't know. Okay. DPP-4 inhibitors are a class of incretin-based therapy. Example, sitagliptin approved in 2006, vildagliptin in 2008, Saxa in 2009, linagliptin in 2011, and I think alogliptin in 2013. They work by prolonging endogenous GLP-1 action, thus making modest amounts of insulin to be available against the circulating glucagon. So the balance is favored for insulin against glucagon. And then it can be used, they can be used as add-on therapy to insulin or to metformin, or they can be good substitutes or alternatives where there is metformin contraindication, particularly in the initial treatment of type 2 diabetes. This cartoon has just described in a very nice summarized version what mechanism of action of the DPP-4 inhibitors are. They act by inhibiting the ubiquitous enzyme dipeptidase 4, thus making active GLP-1 to be robustly available for biological activity. Recall that the DPP-4 enzyme rapidly mops up those incretin-based peptides, GLP-1, DPP, GIP, from the system, so they will not be available for activity. So if you have a molecule that will block that enzyme, then you will have more incretin benefits. They have side effects: arthralgia, pancreatitis, upper respiratory tract infection, increased risk of heart failure, renal impairment, okay, except in linagliptin, severe hepatic impairment, which will contraindicate the use of some of the DPP-4 inhibitors like linagliptin, sitagliptin, alogliptin, and teneligliptin. They are not known to cause hypoglycemia, and they remain weight neutral. There is, these days, you talk about cardiovascular safety for each medicine that you want to put into use. So for the DPP-4 inhibitors, the cardiovascular outcome trials are shown on this slide. I would like for you to focus on these landmark studies, Savotimi, Examine, Tecos, Cabellina. They are not the subject for our discussion. But what do we take from these landmark studies? It is that their primary outcomes were the presence of 3-point major adverse cardiovascular events or 4-point major adverse cardiovascular events. And for all of this, just look at the last row. The conclusion is that they are all cardiovascular safe. Okay, so in terms of answering questions as to the safety of DPP-4 inhibitors, they are safe for cardiovascular patients. Now, we are looking at insulin secretagogues, but this time around, non-sulfonylureas insulin secretagogues, the class called the meglitinides. An example is nateglinide and repaglinide. And nateglinide approved in 2009 and repaglinide 2013. Their main mechanism of action is similar to the conventional sulfonylureas. They inhibit ATP-sensitive potassium channels on the pancreatic beta cells, and thus, as I put it, usually when I teach medical students, they massage the pancreas to produce the stored insulin that they have. So you require residual beta cell function for these secretagogues to be active. They are good for postprandial hyperglycemia. They could be used as initial therapy, particularly where metformin intolerance is prominent. They could be used as combination therapy. Repaglinide is particularly useful in patients that have chronic kidney disease. Again, they carry the risk of hypoglycemia and weight gain, but not to the severe extent of conventional sulfonylureas. And the meglitinides, I must say, they are non-sulfonylurea moieties of glibenclamide. Then the sodium glucose co-transporter 2 inhibitors. We have said that these entrants are quite recent. Canagliflozin in 2013, DAPA 2014, EMPA 2014, and etugliflozin in 2017. How do they work? They promote renal excretion of glucose and thereby modestly lower elevated blood glucose level in patients with type 2 diabetes. So they have, if you like, glucosuric effect, and they act at the proximal convoluted tube to prevent the avid reabsorption of glucose that takes place at that level. And so you have a glucose thrown into the genitourinary tract, and then you find glucose in urine. So a note for practitioners, particularly our friends in general practice, that it is not alarming to see glycosuria in some of your patients with diabetes. You need to take a good drug history to find out if they are taking an SGLT2 inhibitor. Again, they can be used as standalone, or they can, particularly where there is contraindication to metformin, or they can be used as add-on therapy to other blood glucose lowering agents. In an analysis of SGLT2 outcome trial data, it is suggested that people with type 2 diabetes and peripheral arterial disease have greater absolute outcome benefits from the use of SGLT2 therapy. There is overexpression of SGLT2 that leads to hyperglycemia. I think this is what informed their modulation or modification as one of the tools. And then the SGLT2 inhibitors, they reduce renal absorption of glucose by as much as 40%. And then they increase the excretion of glucose in urine. So they have glucosuric effect. In terms of weight change, they are remarkable for improving or making the patients that are obese taking SGLT2 inhibitors to lose weight. And this is of benefit. They are cardiovascular safe. And this is seen if you look at canagliflozin and empagliflozin that have shown significant benefit in terms of major adverse cardiovascular events, or they benefit patients with heart failure. I think this has to do with the volume effects that they contract when they are put to use. Examples of agents in this class are empagliflozin, dapagliflozin, and etugliflozin. In terms of progression to diabetic kidney disease, the agents in this class that are of proven benefits are canagliflozin, dapagliflozin, and empagliflozin. And of course, they do not carry risk for hypoglycemia. Etugliflozin, which is the newest member of this family, was approved in 2017, can be used as monotherapy or in combination with metformin. And then it has modest benefits in improving glycated hemoglobin. In this trial, the VERTIS cardiovascular trial by the American College of Cardiologists in 2020, patients with type 2 diabetes were included. Etugliflozin was found to reduce the risk for first and total heart failure and heart failure stroke cardiovascular death, adding further support for the use of sodium glucose co-transporter 2 inhibitors in primary and secondary prevention of heart failure. This is a landmark study, and this also adds to the volume of evidence that presently exists for the cardiovascular safety of SGLT2 inhibitors. Now, sotagliflozin is a dual inhibitor of sodium glucose co-transporter 1 and 2 as a treatment for both type 1 and type 2 diabetes mellitus. It has a long half-life of 29 hours. It's eliminated in urine and in feces, and it's used as 400 milligrams per day tablet formulation, currently approved for use in Europe. The trial that supports the benefit of sotagliflozin is represented by the SCORED and SOLOIST studies. This study, which I will not dwell into greater details, showed conclusively that in terms of the presence of protein in urine and in terms of the decreasing chance of heart attack, you have a robust benefit as much as 32% if you are using sotagliflozin, and as much benefit in reducing stroke by 34%. And this is quite remarkable if you were using sotagliflozin. This we learned from the SCORED study. In terms of the SOLOIST study, the findings are quite similar, that you will reduce the risk of death from cardiovascular causes and reduce the total time of hospitalization and the need for hospital visit for heart failure by 33% if you were using this dual SGLT2, SGLT1 inhibition. So again, like we did for the DPP4 inhibitors, if you look at the SGLT2 inhibitors, what are the landmark trials? This could be a subject of discussion at a typical Part 2 postgraduate exams. I don't say I'm giving any expo. So the EMPA-REG outcome, the CANVAS, CREDENCE, Declare to Me, and the etugliflozin cardiovascular outcome trials, which also have as primary endpoints 3-point MACE, and then in terms of CREDENCE, end-stage renal disease or the serum creatinine doubling time, and the renal or stroke cardiovascular death. All of them, again, focus on the last rule, that they have reduced rates for these cardiovascular events, and they are all found to have cardiovascular safety. So we have noted two classes of newer oral hypoglycemic agents, the DPP4 inhibitors and the SGLT2 inhibitors, which have been proven beyond doubt that they have cardiovascular and to some extent renal safety. In terms of side effects, the common side effects for SGLT2 inhibitor is that there is genitourinary tract infection. Of course, if you are throwing glucose into the genitourinary tract, it forms a good medium for proliferation of microorganisms. Acute kidney injury, hypokalemia, dehydration. I must mention that. Dapagliflozin conveys a modestly increased risk of breast and bladder cancer. But I must say that in my few years of experience with the use of DAPA, I have not seen patients with breast cancer and bladder cancer, but it is documented. Canagliflozin is known for increasing chances of bone fractures or pathological fractures and the risk of loss of limb. But in all, we have said again and again that they are cardiovascular safe. Another class of oral hypoglycemic agents that is relatively new that I would like to talk about is imiglinine. Imiglinine, the first in a new tetrahydrotriazine containing class of oral antidiabetic agents, are also referred as glimines. Okay, how do they work? They work via multiple mechanisms of action, and they have been shown to increase insulin secretion, they reverse pancreatic beta cell dysfunction, and they prevent death of human epithelial cells, thus suggesting that they have the potential for end organ protection. Though not yet approved by the US FDA, imiglinine may provide a valuable new treatment option in the near future. Imiglinine was compared with metformin in two studies consisting of 4 weeks phase 2A and an 8-week phase 2B studies. And it showed clearly that there was a better tolerability and efficacy compared to metformin if imiglinine was used. Let's look at inhaled insulins. My task is to discuss oral hypoglycemic agents that are new. I thought inhaled insulins will fall into this category. So pardon my ambition in bringing this to you this evening. They are a new formulation They are inhaled as dry powder. They are absorbed faster than injection insulin lispro. Note that injection insulin lispro is an ultra short acting insulin analog. They have shorter duration of action, and they are moderately effective in reducing HbA1c. The example of inhaled insulin that was commonplace was Exubera, that was FDA approved in 2006. It came as a white stroke off-white powder. Exubera delivers insulin by oral inhalation. Just think about somebody using insulin the way you use your inhalers for asthma. It has an onset of glucose lowering activity within 10 to 20 minutes, acts for about 6 hours, could be used in both children and elderly, but unfortunately was discontinued, I guess, because of increased risk of oral mycotic infections. Then Afrezza is another FDA-approved inhaled insulin that has the peak insulin levels within 15 minutes from the time of administration and the duration of action for up to about 3 hours. The boxed warning for Afrezza as an inhaled insulin is that you must be wary of acute bronchospasms in people with airway limitation, like in chronic obstructive airway disease or in patients with asthma. How about oral insulins? The oral insulin are represented by a few examples that I'll be discussing. Insulin Tregopil, which has completed a phase 2, phase 3 clinical trial, acts via ornithine decarboxylase stimulation, phosphokinase stimulation, and protein tyrosine kinase stimulation. They come as 15 milligrams tablets, and they take up to 10 to 15 minutes prior to each major meal for administration. And the Tmax is 20 minutes. They conserve a good safety profile, and they have a good clearance profile. Another oral insulin is Oralin. Oralin is a buccal spray formulation that can be used for both type 1 and type 2 diabetes patients. It's approved in Ecuador. It's currently in use there. It has successfully in a phase 2, later part of phase 2, phase 3 clinical trial, and it's absorbed via the buccal mucosa. Another oral insulin is Oramed, which is in phase 3 trial for people with type 2 diabetes. Comes as oral capsule formulation of recombinant human insulin, and it facilitates uptake of inhibiting proteolysis in the small intestines and improves translocation of peptides across gut epithelial lining into the systemic circulation. The dose is 60 milligrams once weekly. It is safe and it is efficacious. I try to put this summary table here, which looks busy, but at your own time, you could digest this, that conveys greater details of what presently exists as oral insulins. In our practice here in Nigeria, we are not currently using oral insulins, but we know that one of the main themes of this conference is brain drain, is it? Yes. For endocrinologists. So should you find yourself in countries where these things are used, it should not sound strange to you. Having discussed this, are there newly identified target sites looking then into the future for the treatment of type 2 diabetes? To answer this question, I would like to talk about protein tyrosine phosphatase 1B inhibitors. These PTP1B are involved in negative regulation of both insulin and leptin action. So it therefore means that they have benefits, at least in experimental knockout mice. They have benefits for control of weight, obesity, and for metabolic benefit in controlling hyperglycemia. So there is a normalization of blood glucose levels, and there is insulin sensitivity that is improved at the cellular level if you use PTP1B. Then there is glycogen synthase kinase 3 inhibitors. And these enhance insulin sensitivity and promote glycogen synthesis. They provide viable therapeutic target for the treatment of type 2 diabetes. The physiological function in insulin sensitivity tissues, particularly in glycogen metabolism, is enhanced. There is also hormone-sensitive lipase inhibitors. And these, HSL, hormonally regulate the release of fatty acids and glycerol from adipose lipid stores. The inhibition of HSL improve insulin sensitivity and blood glucose handling in people with type 2 diabetes. There's also beta-3 adrenergic receptor agonists. And these have they are used as therapeutic targets to combat obesity and metabolic diseases. They have role in thermogenesis, modulation, lipid oxidation, and glucose consumption, yet remain cardiovascular safe in terms of side effects. Are there drugs in the pipeline? What should we look up to in the coming, for instance, 5 to 10 years? I will just name them. I won't go into the detail. Epiglinatide, ITCAS 650, which is exenatide osmotic mini pump, exenatide extended release, insulin FC. Okay, these are medications in the pipeline. There are others like the GPR119 agonist, which is in phase 1, and then the glucokinase activators, the tetrahydrocannabivarin, which are in phase 2 trials, and then the ranolazine, which are in phase 3 trials. I'm just mentioning this in case you are challenged at the exam to talk about these agents. You should be able to say one or two things. There is the dual PPAR, peroxisome peripheral activator receptor alpha and gamma receptor agonist that act via the alpha targets to modulate dyslipidemia and cause an improvement, and then the gamma targets by working on glucose level to improve glucose disposal at the peripheral level and improving glycemic issues. Examples, this dual PPAR receptor agonist, aleglitazar is currently in phase 2 trial, and saroglitazar is considered a potential candidate in the treatment of metabolically associated fatty liver disease, which is becoming a topical issue due to their benefits for dyslipidemia. There are newer targets. In the future, people are looking at these agents, the OncoCN, the Indigene, the vascular endothelial growth factor B blocker, the ABHDH-D6, the FFAR3, and so on. The list is quite enormous. So I'm gradually rounding up this talk, my dear colleagues, this evening. A summary slide of glucose-lowering agents for type 2 diabetes and their associated factor is given in this busy slide. Again, at your own time, please digest it and we could talk. In terms of novel therapies, since my task is to talk about novel therapy in treatment of type 2 diabetes, this table attempts to summarize much of what I have discussed, and then if you go through it, if you have questions, we can always talk. What is my take home? There are a great deal of molecules that are now making their entrance into the type 2 diabetes management space. And there is extensive research revolving around pathophysiology and then basic sciences in the development of agents that can help to treat type 2 diabetes. And this is commendable. But the disease burden still remains unacceptably high. And it is hoped that a cure may be found someday soon. Well, whatever the sophistication in pharmacotherapy, I dare to say that we must always emphasize the great importance of lifestyle measures in the prevention and management of type 2 diabetes. These are my references. I would like to thank you for your time.
Thank you so much, Prof. Local for that well-delivered lecture and excellent presentation, sir. We really appreciate all that you've said. So to quickly take us so that we can have the very last section and take questions as regards Prof. Loco's presentation. So I'll quickly wrap up and summarize what he said. So he talked about the burden of DM pathophysiology. He talked about the historical events of molecule developed for the management of DM, looked at some landmark studies, and now he went to the newer molecules of what we have. He looked at the SGLT2 inhibitors. He looked at sotagliflozin, which is a dual inhibitor for SGLT1 and 2 inhibitors and is approved in Europe. He looked at also the landmark trials for SGLT2 inhibitor, the EMPAREX study, Canvas study, Credence, Declatimi. He went further again to look at newer molecules novel molecules that are coming up. Some are still in their phase 1 and phase 2 trial. He looked at the imeglinin, refers to that glimins, which includes insulin secretion. It looked at inhaled insulin as a dry powder, which is Exubera. It looked at Afixa, which is an inhaled insulin, oral insulin, which is still in phase 2 and 3 trials. It looked at other oral insulin, which serves as either spray or tablet. He also went further to look at oral med, which is still in phase 3 trial, which is an oral insulin. He now went further to look at glycogen synthesis kinase 3 inhibitors, which is to enhance insulin secretion, which is upcoming. He looked at hormone-sensitive lipase inhibitors, beta-3 adrenergic receptor agonist, and he now finally concluded with the drugs in the pipeline, to which he mentioned insulin FC, exenatide extended release, epligenatide, and he now looked at newer targets like indigene and oncon medication. So these are the medications he looked at, and he now wrapped it up that despite all these newer molecules, the lifestyle modification, is very paramount in the management of type 2 DM, and it shouldn't be underestimated, even with the newer molecules that are upcoming in the management of diabetes. So with this, I summarize Prof's presentation, and now we'll be taking questions, comments, and clarification. If you have a question, please raise your electronic card, and if you are not talking, kindly mute your mic. There are already questions in the platform already for Prof, and I will just take them so that I can answer them all together. So he said, the first question is from Dr. Balarabe. He said, thank you, Prof, for a well-detailed presentation. I need more clarity on dual SGLT2 inhibitors in the management of DM, especially type 1 DM. Thank you, sir. The second question goes like, thank you, Prof, for this lecture. Please, has there been any practical use of these newer agents for type 1 DM, such as SGLT2 inhibitors, as seen in some literatures now? Another question, that's from Dr. That's from, let me just look at it. SGLT2. So the next one is for Dr. Isiawe. He says, thank you very much, sir. Please, is there any role of bromocriptine in diabetes treatment? Now looking at Dr. Sulaiman, he says, thank you, Prof. Please, in our current practice in Nigeria, are there patients that will benefit for tepizumab? If yes, what will be the criteria for selecting type 1 DM that will benefit from them? I think those are the comments in the chat box. And pending other questions, pending the time other questions come in, Professor Loco will address these questions. Thank you so much. Thanks for your patience. Prof, sir.
Okay, thank you very much. Can I take from bottom up or from
yes, any pattern?
There is no pattern to it.
Yeah.
Okay, the question from Abdulaziz Balarabe is that he needed more clarity on dual SGLT2 inhibitors in the management of DM, especially type 1. Yes, I have mentioned it, that they have a place for the management of patients with DM type 1, particularly those that are on the obese side, note that one of the benefits of the SGLT2 inhibition is weight control. Whether we have experience with the use, I think I will just use this to answer the next question. Somebody is asking, please, has there been any practical use of these newer agents for type 1 diabetes, such as it has seen more in literature? Yes, there is benefit in people with type 1 diabetes, particularly those that are obese type 1 diabetes. But in our environment, the experience is not robust. I have no personal experience in placing patients with type 1 diabetes on SGLT2 inhibitors, but it is described, it is done, particularly the dual SGLT2 inhibitors, which is said will have benefits in them. The next question is from Dr. Afoke, who is asking about the role of bromocriptine in the management of type 2 diabetes. Sorry, for the amount of time available to me, I couldn't go into individual molecules. Bromocriptine, yes, is used for management of type 2 diabetes. Recall the pathophysiology of type 2 diabetes that I described, and I said there is insulin resistance at the level of the brain, and there is the role of the central nervous system via mechanisms not fully understood. Bromocriptine has benefits in blood glucose lowering. Whether this is addressing insulin resistance at the brain, I don't know. But yes, it is listed as one of the medicines. And if you look at the tables, I have shown two tables in the course of this talk this evening. The first table was the one that was color-coded, if you recall, red, green, yellow. Bromocriptine is clearly listed there, and the characteristics and the shortcomings of using bromocriptine, they are also listed there. Let's recall that bromocriptine is primarily designed for the management of hyperprolactinemia, and its use in blood glucose lowering is a recent information that was discovered by, again, serendipity, and the consideration that there may be a role for use of dopamine agonist at the level of the central nervous system. What's the last one? Sorry.
What's the current practice in Nigeria? Please, in our current practice in Nigeria, are there patients that will benefit from teplizumab? Yes.
Yes, teplizumab is one of the biologicals. Is one of the biologicals that is used in the management of diabetes, particularly type 1. In Nigeria, I don't have experience using it, but it's known, not only teplizumab. I have a list of other biologicals that have some place in the management of type 1 diabetes. Recall that type 1 diabetes is perceived to be largely autoimmune disease, and these biologicals have some effect in improving this autoimmunity that exists robustly in people with type 1 diabetes. But if you have information as to where they are using it in Nigeria, I would like to learn from you. Thank you.
So thank you so much, Prof. Oloko, for that well-answered questions. It has really been a very interesting day today, and we are really glad for you coming and for all the time you spent in giving this very excellent lectures, despite all that we have to do. So we'll be moving to the final lecture, and the final lecture is the 10th lecture for the... They will have the president's remarks. Okay, so okay, because the president is very, very busy now, and it might be entering into another meeting any moment from now. Please, we want to have him give us the president's remark for this pre-conference update. Thank you, sir.
Okay, good evening, my dear distinguished senior colleagues and colleagues. It's wonderful to be gathered here again for another pre-conference update. As it is customary, we usually go to the venue of the pre-conference update to at least shake hands with our friends, colleagues, everybody that has taken pain to attend. This time we are doing it virtual. And I think there is a lot of wisdom in this virtual participation, given the unfriendly economic environment in Nigeria at this time. You have all made great sacrifices to make EMSON stand out as our professional body that represents the interest and promotes advocacy in EDM nutrition material issues in Nigeria. So I would like to thank you for finding time to be here. I went through the program outline, and interestingly, to make it more EDM and N, there has not been any unusual emphasis on diabetes. I think I'm the only person that gave a diabetes talk in the whole of this meeting from this morning to this time. And so which is the way to go? That each time we gather as endocrinologists, it is not about diabetes alone. I've seen all array of lectures delivered, cutting across the spectrum of endocrinology, diabetes, metabolism, and nutrition. This is excellent, and this is the way to go. And you have all contributed in making this a success. It remains for me to thank the organizing committee, to thank in a very special way this energetic and untiring chairperson of the scientific subcommittee, who has been spending sleepless nights. You see the emails she bombards you with, the calls, the WhatsApp messages, the organizing, the reminders, the messages she pushes through, they have been quite enormous. Together with her team, they have pulled this through. It remains for me, on behalf of the members of EXCO, of the Endocrine and Metabolism Society of Nigeria, to thank you very specially for making this a reality and a huge success. It also goes to say that the chairman of the Central Organizing Committee, Dr. Akinlade, has done excellently well by putting up a great team that has delivered an excellent pre-conference update. They say the taste of the pudding is in the eating. So what we are going to be seeing from tomorrow is tasted from today. So please do well to join the full conference starting tomorrow morning and see what Lagos has in stock for us. We trust that they are a center of excellence, and this conference is going to be exceptionally excellent, like they have always done before. We thank you very much. We'll be talking some more during the conference proper when we meet tomorrow morning. Good evening.
Thank you so much, Prof. Thanks for the kind words. We really appreciate you. Thank you so much. We can do our electronic hands and clap for Prof for that very excellent remark. So let's be clapping for him. Okay. Yes, thank you. Thank you so much. So we'll move to the final lecture now, which is going to be delivered by no other person than Professor Abiola Oduwole, and she's going to be talking about evaluation and management of short stature. Evaluation and management of short stature. So I'm going to quickly take a profile of Professor Abiola Oduwole. So I'll take a profile, and Professor Abiola Oduwole is a professor of pediatric endocrinology in the College of Medicine, University of Lagos, Nigeria, and an honorary consultant pediatrics at the Lagos University Teaching Hospital. She's also the head of Department of Pediatrics, CMU LUTS, the chairman of University of Lagos Medical Center Board. She has MBBS training in University of Ibadan and graduated in 1980. Where was I then? In 1986, she decided to pursue her postgraduate studies in pediatrics at the Lagos University Teaching Hospital and completed them in April 1993, earning the title of the Fellow of West African College of Physicians. In 1993, she began a clinical fellowship training in pediatrics endocrinology in the Division of Endocrinology of the Hospital of Sick Children in Toronto, Canada. Upon her return, Professor Oluwole became a faculty member of Department of Pediatrics, CMU LUTS. Professor Abiola trains undergraduate and postgraduate students at CMU LUTS. She published over 65 papers in peer-reviewed journals. She's the chief coordinator of pediatric training for West Africa and established through a grant from the World Diabetes Federation. The Pediatric Training Center for West Africa has trained more than 50 pediatrics endocrinology from different West African countries, both in Ghana, Cameroon, Ivory Coast, Senegal, Liberia, Guinea, Togo, and Nigeria, starting since 2012 till date. Subsequent to the training of the Pediatric Training Center for West Africa, edition of pediatric endocrinology training program was started in Cameroon and Senegal in 2023. More than 50% of their facilitators are trainees who graduated from the training center for West Africa that she founded. Professor Oduwole's leadership role in professional societies underscore her influence and recognition in the field. She has served as the past president of African Society of Pediatrics and Adolescent Endocrinology and current chair of ASPAE, Educational Committee. Additionally, she holds the esteemed position of President of Society of Pediatrics and Adolescent Endocrinology in Nigeria. Prof. Oluwole delivered a professional inaugural lecture titled "IPO and IPA, the Enigma of Life" at the University of Lagos, Nigeria. In 2019, she won the 2019 award of International Outstanding Clinician Award. Professor Oduwole is the National Coordinator of Life for a Child and Change Diabetes in Children program in Nigeria. She's a dedicated professional, also cherishes her personal life. She's happily married and enjoys the blessings of children and grandchildren. Please join me as we welcome the one and only Professor Abiola Oduwole as she delivers a lecture on evaluation and management of short stature. Please, let's appreciate her.
Good day to everybody. I'm Professor Abiola Oduwole, a pediatric endocrinologist. I'll be giving you the lecture today on short stature. And I've titled this as "I am short, helping grow taller," because this is a question that a lot of these babies, their mothers, the child is asking. I want to grow taller. Now, growth assessment is very important in pediatrics because it's a sensitive indicator of health and the quality of the child's psychological environment. Disturbances of growth, which is the height, weight of both, can occur due to various reasons. And when it happens, you have to start thinking, what's the problem? You have to, what is normal growth? It's important. But I have to stress this, that even when you look at growth, it is still individualized. That is, the ultimate goal for an individual is to follow their own consistent, what is consistent growth curve at the normal adult size. And because we have come to appreciate this individualization, that is why now you have growth charts for turners, or downs, achondroplasia, and many other, because we have got to realize that putting these people in the normal growth chart is not fair. It makes them always too short. But when you put them on their own, you find some of them in the 97th percentile, and that gives them a kind of good feeling that they're doing well. So the word is consistent pattern. How is this child doing? How is this child growing? How is it developing? That is the important aspect. You monitor. So it shows that for you to see about the short stature, obviously from here, we must be monitoring. So when you have population versus individual, a child may not fit the population, like we have said, but just put him on the appropriate growth chart for who he is, you find that the child is not as short as it is. So at every opportunity, growth parameters must be measured, and not just measured, it must be put on the growth chart. It's putting on the growth chart and enables you to rating, is this child just in a plateau, and that determines what you will do. Now, the mechanism for growth is very difficult to say this is how it happens. We know that everything is at the growth plate. So people say, no, it's only neuroendocrine, and and the nervous system is like a thermostat. But a lot of people have said that there are other things that do affect growth, that affect the cartilage, where the growth actually is at the cartilage at the growth plates, where there's a lot of to say. So how is the growth tool? Is the growth chart. Open growth tolerance, because this is the question that a lot of these babies, their mothers, the child is asking. I want to grow taller. Now, growth assessment is very important in pediatrics because it's a sensitive indicator of health and the quality of the child's psychological environment. Disturbances of growth, which is the height, weight of growth, can occur due to various reasons. And when it happens, you have to start thinking, what is the problem? You have to, what is normal growth? It's important. But I have to stress this, that even when you look at growth, it is still individualized. That is, the ultimate goal for an individual is to follow their own consistent, what is consistent, will come to appreciate this individualization. That is why now you have growth charts, or turners, or downs, achondroplasia, and many other, because we of course realize that putting these people in the normal growth chart is not fair. It makes them always too short. But when you put them on their own, you find some of them in the 97 percentile, and that gives them a kind of good feeling that they're doing well. So the word is consistent pattern. How is this child doing? How is this child growing? How is it developing? That is the important aspect. You monitor. So it shows that for you to say somebody short stature, obviously from here, you must be monitoring. So when you have population versus individual, a child may not fit the population, like we have said, but just put him on the appropriate growth chart for who he is, you find that the child is not as short as it is. So at every opportunity, growth parameters must be measured, and not just measured, it must be put on the growth chart. It's putting on the growth chart that enables you to know, is this child accelerating? Is this child decelerating? Is this child just in a plateau? And that determines what you will do. Now, the mechanism for growth is very difficult to say this is how it happens. We know that everything is at the growth plate. So people say, no, it's only neuroendocrine, and and the nervous system is like a thermostat. But a lot of people have said that there are other things that do affect growth, that affect the cartilage, where the growth actually is at the cartilage at the growth plate, where there's a lot of remodelization, regrowing, removal, and so on, under the influence of many things. And so the growth plate hypothesis is one that most people tend to say. So how is normal growth measured? The goal tool is the growth chart. Without the growth chart, you cannot say a child is short. So you need to have the growth chart. And we have different growth charts for height, for weight, length, age, and sex sensitive. So because of this, many countries have their own national growth charts. But unfortunately, in Nigeria, we do have one that the Society for Pediatric Endocrinology in Nigeria, of which I'm the president, have developed. But during one of the PAN meetings, we actually presented this growth chart, and the feedback was that we needed more. So that's why we have not launched it. We're trying to get more figures, up to 15 to 20,000 children. Then we put it into the analysis, and we'll now be able to see this is a project. And we also will make sure it's spread throughout the country so that it accommodates everybody on the project. So widely used is the WHO CDC. The CDC is the one we've always used before it was observed that many of the children in the underdeveloped countries were always being stunted, 80%. And we felt this was not okay, that something must be wrong there. So it was then realized that most of the babies or children used for the CDC were formula fed only. And you know what that means. So they now decided to look for babies, and it's a global thing. And we developed the WHO. The only problem with WHO is that the age that it covers is not so wide. So invariably, by the time you get to the age of 12, you have to go back to the CDC growth chart to be able to chart the child's growth. So the key measurements are the height, the weight, and the mass, and the body mass index. So, and also a single plotting cannot do. You need to monitor. So before you can say it's precious stature, you must have monitored over a time. So do I know you are short? How do I know? There's a definition, and that's the definition there. And this growth chart shows, this is the growth chart we're talking about. This is the percentile. WHO have this, the SD, standard deviation, and we have, and then this one's in percentile. So you can decide to use any one, but the important thing is to plot the growth and the height and weight, honestly. Now, I was talking to you about that. When you're talking about growth, it is more than that. Say, chronic illnesses, your psyche, nutrition, all this will affect the neuroendocrine, your genetic factors, that is the potential your parents have given you, hormones and growth factors, and this will all affect the target organs. So what are the requirements for growth? Nutritional factors are very important. So you must have appropriate macronutrients, appropriate micronutrients, because they all do different things. So because as a result of malnutrition, 43% of children in developing countries suffer from growth retardation, marasmus, and kwashiorkor are two diseases that can result from malnutrition. So malnutrition early in life was not only retardation, but also that. Now, let's see, so intranutrient growth is very important. That chart has gone because I am recording, but I think you will see. So I just talk about it. What we're saying is that in utero there are two phases. We have the embryonic phase, which is the early part of the growth, and most of things going there, hyperplasia, hypertrophy, apoptosis, the cells that is not needed, so that you now have something that looks like a human being is great. Then you have the fetal stage. During the fetal stage, there are two things you need. When you think of the height and weight, for the weight, usually the child starts slowly, about 10, 9, 8 weeks need to register a weight that you can say is weight. And it grows exponentially until it gets about 37 weeks. About 35, 37 weeks, it starts, not that it's not gaining weight, but the rate of weight begins to decelerate. If not, how would the mother carry that weight? It will be too much, so it decelerates. So it starts decelerating, and once the baby is born, it picks up again. Now for the length, it's a different ballgame. In the length, the baby, there's this accelerated one of the first 18 weeks, the length, and then by the time the child is 20 weeks, there's also deceleration. It has to happen. If not, how would the womb contain that? So it decelerates. Not that the child is not still increasing in length, but the rate of increment is reduced until the child comes out, and then it continues to go. So what helps this baby to go through this? We have IGF. IGFs, all the IGFs role. The IGF play a central role controlling fetal growth, including insulin. Genetic defects affect the birth can also affect the birth so that the child is smaller. And there are also maternal limiting factor. Maternal limiting factor, you cannot grow past the womb, so it will constrict the child if it doesn't have enough space. If for any reason there are other things that are there, like fibroids, like the placenta and this. Also, because it's the mother, other things that be wrong with the mother, severe hypertension, not well controlled, diabetes, not well controlled, they also affect the growth of the child. Now, the baby is out. It's out to us, and we are the ones having this baby. So the growth in the postnatal period depends on many factors. The height is up to 70% determined by genetic factors. That is, your parents. You actually can grow more than what your parents have given you. So, but other things may affect even that potential so that you don't reach it. So apart from that, emotional as is a strong thing that can also affect babies. Now, insufficient nutrition, of course, is going to affect chronic illnesses, is going to affect hormones, growth factors. They play important roles in regulating postnatal growth. And there are other hormones, the growth hormone, the glucocorticoids, thyroid hormone, all these things will affect. Now, this table is just to show you what the different hormones do, like growth hormone, IgG synthesis, insulin, regulation of glycogen storage, thyroid, CNS, vitamin D, your bone and mineralization, sex and pubertal growth. Glucocorticoids, which are encouraged growth, but when it's too much, it will cause irritation. Now, this figure shows the influence of different hormones on the various phases of growth. In the infancy, showed by this, the line, the phase between the blue and the green. Okay, growth hormone does not have any. It is nutrition. How much food, the kind of food, the kind of diet, the frequency, the calorie contents. Those are the things that affects the growth. And that's why you find a child that is very fat, but by the time it stops, all that and starts to slow, just find the child is no longer as fat as before. That's because the food is no longer like was being given in that time. Okay, but between the green and the red, the child, the growth, all these hormones become very important. Growth hormone and thyroid hormone. will certainly affect. After the red, when the child goes into puberty, sex hormones are the most important in collaboration with the growth hormone. So let's talk about short stature. Now, short stature is a problem that requires the caregiver to decide whether a child is small size, represents a normal variant, or indicates the presence of an underlying disease. And below, here are the definition for determining. So to see that chronological age is very important, the height velocity is very important, and also the mean parental height, which is the, who gives you the target height, the possibility of where this child can go. So what are the causes of short stature? We've divided the cause into two main things, proportionate and disproportionate. So proportionate means that when you look at the ratio of the head to the trunk to the limbs, it's okay. Disproportionate means there's a problem with the ratio. So under the proportionate short stature, you have normal variance. That is the familial or the constitutional group delay. And then you have prenatal causes, inter-infant growth restriction, intestinal infections, genetic disorders, and metabolic disorder. You have postnatal causes, that is undernutrition, chronic systemic illnesses, sickle cell disease, cardiovascular disease, severe asthma, who's also on steroids, malabsorption, and so on. All this can affect. And as I always say, psychosocial structure. It's so important because these children, when you remove them from their home, take them to another place, they flourish, they start growing, they get taller. Take them back to where they were before, they just go back. So, and then you have the endocrine causes, growth hormone, hypothyroidism, diabetes mellitus, Cushing's syndrome, pseudohypothyroidism, precocious or delayed puberty. Then the big group again, disproportionate short stature. Those with short limbs and those with short. So an example of short limbs is achondroplasia, and an example of short trunk mucopolysaccharidosis. Now, this is a summary of the various causes of small stature in childhood and adolescent nebular form. So you have nurture, familial, delayed puberty, SGA, chronic illness, chromosomes, syndromes, body dysplasia, and then set apart is endocrine causes. Now, let's talk about the various things. Now, we're mentioning it can be normal variants. The normal variants are either familial, short stature, or constitutional delay. And if you look at this graph, this is a child with constitutional delay. So it grows, but then it slows down, and then it picks up again. And finally, which is its potential. Whereas familial short stature are those ones, that's who they are, that's what they give it, the parents. And so you find out that they're short, they continue to be just below the -2 standard deviation. So we'll just be slightly above the -2 standard deviation, right? Now this chart compares the two. So we have familial stature, constitutional short stature, and you can see the difference. Like sex is more common in boys, constitutional. Parent stature, short, both of them, one of both. Whereas in constitutional short delay, they are average heights. Family history of short stature, family history delayed puberty. Height velocity is the same. Puberty is delayed. So these are the various things that make the difference. Now, we've talked about the physiological, that is the familiar. Now let's talk about the pathological. So clinically defined syndromes, Turner's, Down syndrome, Winner syndrome, Prader-Willi syndrome. These ones are syndromes that are associated with short stature. Then you have small for gestational age with failure you expect SGAs to catch up. But when they don't catch up, you need to investigate them. And if they have IGF-1 resistance or IGF-1 deficiency, or if you know that during the prenatal, they have been exposed to alcoholism, exposed to smoking, exposed to illicit drugs. But sometimes there's just no reason. That is just them. And even when you do genetic studies, you still don't find any reason. So those are small SGA with failure to catch up. Then you have skeletal dysplasia, such as achondroplasia, hypochondroplasia, osteogenesis imperfecta. Those are skeletal dysplasia. Then you have dysplasia with defective mineralization, such as rickets and other ones. And this is the kind of graph you get. You find that these ones, from the beginning, at the beginning, they were not quite small, but within 2 to 3 years, you begin to see that they're not going anywhere. They just remain on this kind of standard deviation. Then you have B1, insufficient nutrient intake and nutrition. The disorders in organ systems, such as cardiac, intestinal disorders, celiac disease, renal disorders, chronic anemia, like sickle cell disease, then growth hormone deficiency, secondary to IGF-1 deficiency. So associated with syndromes of cerebral or facial malformation. So when you see a child with septo-optic dysplasia, empty cellular syndrome, central incisors, you begin to think of growth hormone deficiency. Sometimes it's acquired. A kind of tumors or trauma or infections, all these things can also affect the pituitary gland. Then other disorders of the growth hormone IGF-1 axis, primarily IGF-1 deficiency. So you have abnormalities of the growth hormone receptor. So it's not just deficiency, it's resistance, it's a problem of the receptor, it's a problem of the acid lipid subunit of the growth hormone. Maybe there's a mutation, there can be a deletion, and IGF-1 deficiency and IGF resistance can also be a post-COVID short stature. This one is genetic study correctly. Then there are other endocrine disorders that are associated with short stature, Cushing's, hypothyroidism, body control, diabetes mellitus, precocious puberty, congenital adrenal hyperplasia. All these ones can also affect. So this is kind of graphic. See the child that says to be doing very well. And then all of a sudden, what happens? It begins to slow down. And invariably, at the end of it, it is short statured. Then there are metabolic disease such as rickets, disorders of carbohydrate metabolism, disorders of protein metabolism, all this kind of psychosocial can also affect the iatrogenic Cushing's syndrome. We have been seeing this quite commonly among children who have adenoids, and the ENT places them on steroids, intranasal steroids, and forget, or the parents, because they have noticed the difference, refuses to stop, and then they come to us with the iatrogenic Cushing's syndrome. It can also occur when you have a child with cancer. Part of the management is steroids, and this can also affect their growth. Or the child may go through radiotherapy, which a total radiation, which will affect the pituitary area, and then it leads to that too. And this similar, you can see, this is a child that's going on the insult of course, and there's deceleration. So, what are the first steps to diagnosis? A thorough medical and family history, birth characteristic, all those physical examination, aiming at detecting the clues, doing the the arm span, doing the upper segment to lower segment ratio. All these are important. So, assessment of height velocity. You cannot assess height velocity unless you monitor this child over time. Then comparison with population norms, make sure you chart it so that will also enable you. Comparison with child's own genetic potential, that is the target that is given by the parents. We use the mid-parental height, and when we calculate it, we now have plus 2 SD, minus 2 SD, and we expect that child to be within that. If it's outside that, either above or below, then you can start talking of a problem there. And then sexual maturity, you have to be able to put the child on what time and staging. And if the child is delayed, you will know that the child is delayed. So what are the clues to etiology from history? History of delayed puberty, you already. Low birth weight, you think of HGA. Neonatal hypoglycemia, you think of growth hormone deficiency. Dietary intake or nutrition. Headache, vomiting, you think of a pituitary or hypothalamic space of opine lesion. Lethargy, constipation, hypothyroidism, polyuria, think of chronic renal failure, and RTE. Social history, psychosocial dwarfism, diarrhea, think of frontiers of etiology, midline defects, micropenis, frontal bossy, think of growth hormone deficiency. Rickets, you think of malabsorption, you think of nutritional rickets, think of renal failure. Pallor, you think of renal, you think of sickle cell disease. Okay, malnutrition, of course, obesity, you think of hypothyroidism, Cushing syndrome, or Prader-Willi syndrome. Metacarpal shortening, of tonus, or pseudo hypoparathyroidism. Cardiac murmur, mental retardation, all these help us. Plus etiology from inside, disproportionate, skeletal dysplasia rickets. Dysmorphism, think of congenital syndromes. Hypertension, think of chronic renal failure. Goiter, hypothyroidism. Central obesity, think of that. So this is just a schematic way of where you have a child with short stature, what you can do, short stature, physiological, even pathological, think of primary growth failure, secondary growth failure, and this will then. So having decided that this data has short stature, you have to do some investigations. So you do these ones that I listed here. Most of the time, you try to tailor your investigations to what you have discovered as the most likely underlying causes of your. You cannot take all this. When you have done that, if you are seeing a symptom, please do a karyotype just to help you gene mutation analysis. Bone disorder, not only for excess of skeleton, we also want to do the bone age. That's why we do bone. Celiac disease, you have to do genital malabsorption. We look for OSIS, we do tests. Renal disorders, GFR, anemia, blood smear, and HB electrophoresis, mucopolysaccharidosis, investigate, and sarcogenic shortness, where every time a child comes in, what we do is we assess the relationship between the child and the parents. Management of short stature in children and adolescents depends on the underlying cause. Hormonal deficiency should be managed with appropriate hormone replacement. Short stature secondary to systemic illness requires control of the primary disease, nutrition counseling, and psychosocial to see a psychologist. I just decided to talk a little bit about growth hormone deficiency. It can be congenital, it can be acquired. And the clinical features are growth failure and delayed puberty. Diagnosis is you have to do a stimulation test. You can either do the history tolerance test, which is the go and this is the one we normally use. That's what is available to us. Luckily, we've never had any incidents of any issue while doing it. Arginine stimulation test, very good, especially if you can get arginine, but only one person will be able to source it, and it was so expensive, nobody has tried it again. And then you have to also mention the IGF-1. Low IGF-1 indicates insufficient growth hormone activity. And when you think maybe there may be a adenoma, a glioblastoma, please do an MRI. Treatment is recombinant growth therapy, monitoring regular IGF-1. Fortunately, we don't have, at the moment, there's no growth hormone. We have growth hormone, but the one we normally use, the Novo Nordisk, is not available, but there are other ones that we also use. I would say we haven't been able to get that same response we got with the Novo Nordisk, not a trophy, but we're still better than nothing at all, and it's still just as expensive. So thank you very much. Thank you for listening. I think I have spent all my time. So thank you and be blessed. Amen.
So thank you so much, Ma. Thank you, Prof. Oduwole, for the excellent delivery and very detailed presentation, Ma. We really, really appreciate you for all you do for us. And let me just quickly summarize all she has said. So all she has said. So she talked about evaluation and management of short stature. So she talked about what a short stature is. She said this can be disproportionate or proportionate. She talked about various causes of short stature, both familial. It can be due to bone dysplasia, delayed puberty. She also further classified short stature into familial and constitutional because some people, they are short in their family. So when you see a child that is coming in short, could necessarily not be any issue. It could just be a familial short stature. So she looked at also growth disorders that can result to short stature. So she categorized it into primary growth disorders and secondary growth disorders. And she mentioned different examples in this category, looking at primary growth disorders, Turner syndrome, Down syndrome, Prader-Willi syndrome. She looked at secondary growth disorders, and she mentioned that different health conditions like cardiac disorders, pulmonary disorders, endocrine disorders, liver disorders could also result, even diabetes that is poorly controlled could result in secondary growth disorder. And she finally now mentioned the growth hormone deficiency that is also related to short stature, and she further divided it into congenital and acquired growth disorders. And she concluded that slide by talking about the need for good history examination for evaluation of a patient with growth disorder in order to properly manage and treat this patient. So I think that will summarize our presentation. She's quite very busy now. I'm not sure whether she's online with us to address any questions that will come up. Please let me check whether Prof is online now. Okay, so I think she's still not online. She's quite very busy. She's quite very, very busy. So Dr. Mohammed says, thank you, Ma, for the presentation. What are the initial evaluations for a teenager that comes with short stature? Unfortunately, Prof is not online now. She's quite very busy. And so I won't be able to answer that question, but I will note that question. I will send it to her. And once she sends the response, I will post it on the pre-conference update group for you to see. I don't know whether there's any other question so that I can post it to her. And once she sends in the answers, I'll post it to the pre-audit conference WhatsApp group for us to look at it. So I think we are gradually wrapping up with this pre-conference update calls. I really want to appreciate everyone for your patience You've been here since morning, and I really want to appreciate your patience and your time, to be in but I believe that the time spent here wasn't a wasted time, it's a time well spent, and I believe all these lectures will greatly impact our clinical practice going forward. In order to wrap up this pre-conference update, we will be having a evaluation form that is going to be placed on the platform for us to evaluate the pre-conference update, and we have to click on that link and make our comments on it. Also, we are going to have a post-test, and with the post-test, we will wrap up the pre-conference update course for EMSON 2025. So we are going to also post the post-test now, where the post-test is just going to run for a very short time, like maybe 10 minutes, 15 minutes. We'll just quickly answer it so that we can eventually wrap up with the pre-conference update course. So the link for the evaluation form has been posted. So we are posting right away the link for the post test MCQ. It's been posted, the link for this. So we'll just allow 10 to 15 minutes to answer the post-test question so that we can wrap up with this meeting. Thank you so much for your patience and for staying tuned till this very time. We really appreciate you all. So thank you. So we run the post-test right away. Am I audible? Okay. So we just run the post-test for like 10 minutes and we'll wrap up. Thank you so much. So by 4:50 we should be done with so that 5 o'clock, before 5, on or before 5, we are done with the pre-conference lectures. Okay, we have 5 minutes more to round up with the pre-test. We have 5 minutes more to round up with the pre-test and the conference. Evaluation form. So let's begin to round up. I think we have 2 minutes more to round up and the post-test. Thank you so much for your patience. So I think it's time for us. So I really, on behalf of the scientific subcommittee, and I really want to appreciate everyone for joining promptly and staying tuned. I really want to appreciate you, because without you being around, there is no pre-update conference at all. I also want to specially appreciate the distinguished speakers that took time out of their very tight schedule to still deliver these delectable lectures. I also want to appreciate the elders, the elders in our midst, the professors, all the consultants, the residents, the house officers, the nurses, matrons, dietitians, pharmacists, and all the paramedics that were part of this virtual pre-conference update calls. I really want to appreciate you. The conference starts fully tomorrow, which is Wednesday. And we are planning to send all the slides to you post-conference. You also get your certification post-conference, but it's going to be after the main conference because of the tight schedules within the conference. So we'll send the slides to the platform, and we can even send it to your individual mails. We'll work on everything immediately after the conference, and you'll get all your certificates. So I really want to appreciate everyone for your time. We appreciate you, because without you being in the air, we don't have any audience and no pre-conference update. Thank you so much, Sazama, and have a very good evening. So bye. Bye for now. Bye. Bye.
Bye.
Thank you. Yeah.
We are starting meeting by 5:45.
Yes.
5:45 now. God, Dr. This was all.
But they said they should move it to 7. I don't know whether they.
Because that was what.
Yes, for me, maybe they agreed or. Hope you've noted.